and his team for inviting me for this presentation. This morning, I'm going to talk about emerging burden of NCDs in Africa, what was there in the past, what is there currently, and what is the future holding for us. And are we really ready for this challenge? My presentation is going to be giving you a short brief on a global NCD perspective, giving you a perspective on the African NCD perspective on a burden, the communicable and non-communicable disease interaction, something on maternal health, something on adolescent health, NCDs in women, and NCDs and COVID-19. And then I'll be talking something on governance, human resources for health. I'll be talking on health financing, supply chain, service delivery challenges, what is a global response, and what is with the way forward. So if you look at the global NCD
my sincere apologies. We have to pause the presentation by Professor Kaushik, the commissioner of, in the African Union, the commissioners are high-ranking officials, and she's online to give her opening remarks. Then we'll go back to Professor Kaushik's presentation. My apologies, Professor Kaushik. Your Excellency. Your Excellency.
Thank you, moderator, but you are not precise about which commissioner are you calling. I just joined the meeting, but I want to know which commissioner you're calling. Are you calling Commissioner Sako? I just want you to be precise on which commissioner.
Yes.
Hello?
Yes, Your Excellency. Yes, Your Excellency.
Commissioner Sako?
Yes, Your Excellency.
Okay. Thank you very much, moderator. Good morning, every one of you. Apologies because there is a 2 hours time. Apologies because I'm in Lisbon. Okay, thank you very much for giving me the floor. Distinguished colleagues, commissioners, excellencies, ministers, and the senior government official present, Dr. John Kengason, the director of CDC, ladies and gentlemen, and all protocol duly observed. On behalf of the African Union Commission, through my Department of Agriculture, Rural Development, Blue Economy, and the Sustainable Environment, I am pleased to address you today at the Member States and the Stakeholder Validation Workshop and the launching of the African CDC Non-Communicable Diseases, Injuries, and Mental Health Strategy of the at the African Union headquarters. I want to express my deep appreciation to my dear brother, Dr. John Kengason, the director of the African CDC, for extending the invitation to me to attend this critical validation workshop and launch. I also want to use this opportunity to thank Africa CDC for the excellent work they are doing in assisting the continent to mitigate the impact of COVID-19 pandemic, including providing real-time data on the spread of the pandemic in member states. Excellencies, distinguished participants, ladies and gentlemen, I am delighted that we are gathered here today to validate and launch the five-year evidence-based strategic plan for non-communicable diseases, injuries, and mental health prevention and control, prepared through a very consultative process by the new division of disease control and prevention of Africa CDC to assist member states to reduce the long-term burden of the diseases that have become major killer in Africa. We all need to rely around and assist Africa CDC and member states to implement this plan. It is imperative to note that collective action is also key to tackling non-communicable disease in Africa. We need to work together to suppress Ncds by minimizing the risk factor of the diseases. One of the lessons from the COVID-19 is that good diet and nutritious foods are overly important if we want to stay healthy. It is therefore not a surprise that African Union adopted the nutrition and the food security as a 2022 theme of the year. My department is implementing several initiatives and programs to boost agriculture productivity in Africa and also minimize the challenge posed by climate change, which is one of the defined challenges of the 21st century, posing significant threats to health and sustainable development and reversing the progress of the two areas achieved in the recent decade. Last year, we successfully produced the following reports to enhance agricultural productivity, food security, and nutrition in Africa. The third biannual review report, 2015-2021, on the implementation of the Comprehensive Africa Agricultural Development Program, CADEP, the African Common Position on Food System, and the CADEP Malabo Business Plan, the Continental Guideline on the Use of Biotechnology policy document to promote livestock development, a agriculture investment plan, and the livestock advocacy paper. All these documents are present, and we really need to work with our member states in order to implement and improve the status of nutrition on our continent. Excellency, distinguished participants, ladies and gentlemen, in the area of environment, we have concluded the African Union's climate change and resilience development strategy and action plan, and the integrated African strategy on meteorology. This strategy framework aims to enhance African resilience to the impact of climate change and enhance climate information services in Africa. We are also processing on the implementation of the African Green Recovery Action Plan. This is a recovery plan that we elaborated during the COVID-19 pandemic in order to really recover our economy and our agricultural sector, and also climate change, especially on a resource mobilization to implement the 5 strategic pillars named climate finance. This is our GRAP pillars, the climate finance, renewable energy. We know that we need to reduce the emission that we are polluting the planet, and also the nature-based solution and biodiversity, resilient agriculture, and the green resilient city. We are also working with development partners to develop an integrated assessment of air pollution and climate change in Africa. The assessment aims to identify intervention for improved air quality in Africa, especially for better human health, ecosystem services, climate resilience, and food security. These policy documents and initiative will contribute significantly to economic and environment and social outcome. They also have a great potential to minimize exposure of Ncds and injuries. Excellencies, distinguished participants, ladies and gentlemen, as I conclude, I would like to take this opportunity to congratulate Africa CDC on this milestone and for recognizing the contribution of other departments in achieving the SDC's goal of strengthening the capacity of national public health institutions to dictate, prevent, control, and respond quickly and effectively to disease threats. I wish you a fruitful deliberation, and I thank you very much for your kind attention. Merci beaucoup por votre attention. Muito obrigado pela vossa atenção. Asante sana. Shukran. Muitas gracias. I submit.
Thank you so much for this excellent speech that has brought out the multi-sectorial approach to prevention and control of non-communicable diseases and mental health. As you've mentioned rightly in your speech, we need to work with all across the African Union Commission, the different commission, to ensure that we reduce the impact and the burden of non-communicable diseases, injuries, and mental health on the continent. On behalf of the Director of Africa CDC, I thank you for finding time to come and address this gathering from the member states of the African Union Commission. Thank you, Your Excellency. So we will go back to, after taking the address from Her Excellency, we'll go back to the presentation by Professor Kaushik. Professor Kaushik.
Yeah, so I'm sure most of you are aware of this, this slide. The only reason I highlighted this slide is because, as you know, that from 4x4, now the WHO has adopted 5x5, and we have in the modifiable risk factor, the environment, which the Commission also talked about. And then on the main chronic disease side, we have got an addition of mental health as one of the key areas of the non-communicable disease. Looking at the burden of NCD, every second, 28 lives between the age of 30 and 70 are cut short because the countries do not have a policy, legislative or regulatory measures to respond to the needs of the people living with or at risk of cardiovascular disease, cancers, diabetes, chronic respiratory disease, or mental health, including preventive, curative, palliative, and specialized care. Unfortunately, 25 out of 28 lives lost each second occur in low and middle income countries where the social, economic, and physical environments afford population much lower levels of protection from the risks and the consequences of NCDs than in high income countries, including protection from tobacco use, harmful use of alcohol, unhealthy diets, physical activity, and air pollution. So if you look at the data in year 2008, you look at the NCDs accounted for 60% of all the deaths with the exception of the African region. And if you look at that graph, and if you see the non-communicable disease, which is a red color, you find that basically in 2008, it was the communicable diseases, maternal, perinatal, and nutritional conditions, which were the major causes of death in the African region in the year 2008 in males and females. Of that distribution of the NCD mortality which was there, cardiovascular disease was number 1, cancer was number 2, chronic respiratory disease was number 3, and diabetes was number 4. In 2010, UN resolution came about 64/265, calling for a UN General Assembly of the Heads of State, which was held in September 2011 to adopt the Ncd Charter. Currently, from the current data which we have, if you look at the leading causes of death globally, you find compared to 2000 and 2019, overall ischemic heart disease has increased, stroke has increased, chronic pulmonary disease has increased, lower respiratory infections have increased, neonatal conditions have come down, bronchus and lung cancers have gone up, Alzheimer's disease has gone up, diarrheal disease have gone down, diabetes has gone up, and kidney disease have gone up. And currently 74%, basically all the NCDs account for 74% of the deaths globally in year 2019. And if you look at the 10 leading causes of burden of disease, and when you compare them from 2004 to 2030, you find that the the spectrum of the disease is changing. So if you look at 2004 and if you look at 2030, you find in 2004, infectious diseases were predominant, while you find in 2030, the non-communicable disease, especially depressive disorders, ischemic heart disease, road traffic accidents, cerebrovascular disease, COPD, and lower respiratory infections become the leading 2030. Again, looking at the SDG 3.4, it is believed that only 14 countries are on track with SDG 14. And there was quite a good acceleration from year 2000 to 2010, but from 2010 to 2020, the acceleration has been slowed down due to various reasons, mainly affected by the low and middle income countries and the COVID-19. Coming to the African region, what are the perspectives in the African region? When we look at the conditions which have been grouped under non-communicable disease and referring to the Brazzaville Declaration on Prevention and Control of Ncds in the African region, we had cardiovascular disease, diabetes, chronic respiratory disease, cancers, mental disorders, violence, injuries, and hemoglobinopathies, and then later on oral, eye, and renal disease were added onto the spectrum. We have very few community-based studies related to Ncds. Some of the countries are overrepresented in the data, and mainly it is the Republic of South Africa. Prevalence of Ncds and risk factors vary considerably between countries, between urban and rural population, and within the subpopulations within the same countries. And the prevalence of Ncds and risk factors are very high in some of the sub-Saharan settings. And what is the major reason for this increasing burden? One, there's a huge societal transition taking place. There's an aging population, there's an increased urbanization, there's an increase in the mean risk factor level and high burden of conventional risk factors, and there's a reverse of the socioeconomic gradient, which is driving this NCD epidemic. What is the overall burden? So if you look at since 2003, there have been 33 countries in the WHO African region who have conducted stepwise surveys, and 19 countries have conducted the general school health surveys. And most of these stepwise surveys were from nationally representative samples. And if you look at the summary of this, you find the summary of the African region. If you look at the mean prevalence, median prevalence, you find tobacco is around 12%, tobacco use in students is around 11% for boys, 4% in girls, alcohol drinking in adults is 21%, heavy episodic drinking is 31% in male, 13% in female, alcohol drinking in students is around 16%, fruit consumption is 2.8 days per week, while vegetable consumption is 4 days per week, and physical inactivity, basically minutes, is only 22. If you look at the school children spending 3 or more hours on sedentary activity, it is 32%, overweight is 35%, obesity is 11%, hypertension is 31%, pre-diabetes is 4%, diabetes is 8%, and cholesterol is 14%. So we have a huge burden based on the median levels of these step surveys which have been done in the region. You can find that we are sitting on a risk factor burden, which is going to contribute to a huge number of diseases. So if I go and look at the historical data, the first data basically on cardiovascular disease and prevalence of large vessel disease in Africans with diabetes came from Ethiopia in 1984. And they reported a prevalence of cardiovascular disease of 1%, CVA of 1.3%, and peripheral vascular disease of less than 1%. And then you have Nigeria, again, reporting almost the same rate. So you find during the years 1980, 70 to 1990, the rates of the cardiovascular disease and large vessel diseases were very low. And if you look at the causes of death developed and in developing world in 1996, you find that in 1997 from the World Health Report, you find that infectious diseases contributed 43% of the death in the developing world, while circulatory system was only 24%, cancer was only 9%, respiratory system was only 4.8%, perinatal and neonatal diseases was 9%, mainly in the developing world, and mental causes was less than 0. It was not even recorded. So you find that over the period of time, over the decades which have gone, you would find that increasing, there has been a shift from communicable to non-communicable disease. Again, if you look at the data of neuropsychiatric burden of disease, which is in the percentage of total dailies in the African region in year 2004, you find psychiatric disorders were put at around 3.4%, unipolar depressive disorders at 1.2%. And this is quite a different from what the figures we have currently. Again, distribution of intentional and non-intentional injuries in the African region, again in year 2004, unintentional injuries were only 5.4%, road traffic accidents 1.9%, and you find everything was less than 2%. This is the study which was done by Professor Mbanya and his team, and this was published in Lancet in 2006, and you can see the evolution of type 2 diabetes in Cameroon from year 1994 to 2003. And you can see in men, in urban, women, and again in rural population, again, there was a steep rise in diabetes over a period of time. In 2012, the non-communicable disease and the percentage of dailies in the African region, the cardiovascular disease again was number 1, which was around 3.8%. Sense organ disorders was 2.5, respiratory disease 1.9, and malignant neoplasms around 1.6. And the shift was already occurring. So in 2013, 1 million deaths were attributable to cardiovascular disease, constituting 5.5% of all the global deaths related to CVDs, and 11.3% of all these deaths were in Africa. Between 1990 and 2013, Sub-Saharan Africa remained the only geographical region in the world where the CVD-related deaths have increased. The CVD burden in Sub-Saharan Africa has been projected to double by the year 2030. So if you look at the data which is available from WHO and the expected in 2025, the mortality, the burden of NCD in the Afro region from 2010, which is around 40% contributing to mortality, is expected to be 55% in 2025. And it might even cross the 55% line. Again, if you look at the regional trends in hypertension and smoking, and if you look at the Sub-Saharan African region, the graph on the left side, where the blood pressure is there, you find Sub-Saharan Africa leading with the blood pressure on the observed and the expected prevalence rates. Smoking, we are a bit better, but still on a higher side. If you look at the EXA region, and if you look at the follow-up which was done after 12 years, and if you look at Kenya, Lesotho, Malawi, Mauritius, Swaziland, Uganda, Tanzania, Zambia, and Zimbabwe, and you find that again, you find the light bar is year 2000 and 2012 is the dark bar, and you can see that again, the NCD deaths have again increased in all these EXA countries over the last 12 years. The same is the case for prevalence of diabetes, expected diabetes rates in Sub-Saharan Africa. Just taking a snapshot of few of the countries, you can find that the rates are going to be increasing more than 114%. And this is from Tanzania, again, looking at dailies at all ages in Tanzania in 1990 and in 2015, and you can find that the NCDs have almost doubled from 1990 to 2015. So we are sitting on an epidemic, which is basically something which is driven by the risk factors, which is driven by something which basically needs to be controlled. And burden of these risk factors is increasing tremendously at a very fast and a very accelerated pace. There is this component of what we call as Ncdis. And with Ncdis is what we call as other non-communicable diseases. And there is an NCDI group which has been working in several countries and looking at the different burden of the diseases related to non-communicable disease and contributing to this one. And this is the data from Tanzania from the Global Burden of Disease Study, which was in 2017. And again, if you find that if you accumulate the other NCDs, you find that the burden of other Ncds also tends to be on a higher side, and it is progressively increasing. So when we are talking of Ncds, we need to have a global approach of not only 4 or 5 or 6 major diseases, but other diseases also contributing towards the overall morbidity and mortality. Again, looking at the risk factor attribution by this disease category in 2017, you find there is a behavioral effects, there are environmental changes, and there are also metabolic changes which are contributing depending on what risk factor and what disease group you are talking about. And there's a variation of the underlying risk factors which you find. If you look at the shared determinants between the non-communicable disease and risk factors related to poverty, and I'll just go through one of the one, that's the cardiovascular, you find hypertension, pericardial disease, rheumatic valvular disease, cardiomyopathies, and congenital heart disease. And when you look at the risk factors due to the poverty, you look at the tuberculosis, you look at streptococcal disease, you look at HIV and other viral diseases, pregnancy, rubella, micronutrient deficiency. So you find that there is a linkage of the socioeconomic status and the NCDs, and especially the NCDIs. And that linkage basically is related to the poverty and the socioeconomic status of the population we are dealing with. There's also a nutrition transition which is taking place, and this nutrition transition is moving towards a high-fat and refined sugar Western diet. And if you look at the nutrition transition adopted from the Popkin here, you can find there's a change in the economic system that brings about change in the physical and socioeconomic and cultural environment. That environmental change brings about changes in diet and physical activity, and this brings about prevalence changes in the nutrition-related diseases. And if you look at this data here, and if you see this data, which is in 1992 to 2000, and if you see the countries in African region, which is Tanzania, Niger, Malawi, and Mali, and if you look at the countries in South Africa, Turkey, Brazil, and Mexico, you find that in Turkey, South Africa, Brazil, and Mexico, those who are more educated were basically less obese. While you find in Tanzania, Niger, Malawi, and Mali, those who were more educated were more obese because they had more education of what type of food to eat, probably more of a Western diet. So you can see that although education, we feel that education, if somebody has lack of education and probably the diet factor or the diet information is not passing through, then we find that it's a reversal in the Sub-Saharan African region. Again, if you look at the BMI trends in Africa, you find from 1980 to 2014, again, there's an overall BMI, mean BMI has increased from 21 to around more than 24 to 26 kilogram meter square, and that is actually driving the overall epidemic in the region. Urbanization, when you change, this is the data from Tanzania again, where the families were followed up when they moved from rural area to urban area, and you can see within 1 year, there was a change in alcohol consumption, there was a change in smoking, and there was a lack of physical activity. So as soon as there was a migration taking place, these three risk factors became basically pronounced in a sense that the physical activity went down, alcohol consumption increased, and the smoking increased. Then we come to the communicable disease and non-communicable disease interaction. You see, this is the data from South Africa, 1997 to 2012, followed up over a period of time. And as you see that HIV, AIDS, and tuberculosis is going down, but you find the non-communicable graph is just going up. It has remained stable, but it is going up slowly and gradually. But the most important component is the multimorbidity. When we talk about the multimorbidity, whether you go into a patient in a clinic which is running hypertension clinic, or you go into an HIV clinic, or you go to diabetes clinic or TB clinic, you start finding that there is other conditions which you are missing out. And these missed out conditions are ultimately and consequently causing quite a bit of a morbidity and mortality. So in this study, which was published in 2015, you find that overall multimorbidity prevalence was around 22.6%, 94% had 2 conditions, and 5% had 3 and more conditions. So multimorbidity and what we call as a chronic disease interaction and chronic disease clinics are very important to make sure that we basically are not missing out on those ones. Again, if you look at this HIV clinic, and if you look at HIV negative and HIV positive, and if you look at the projected increase, which is, this is the data from burden of NCDs in Zimbabwe, and again, you find that from 2015 to 2035, it is projected, then you find that number of NCDs in HIV positive population and HIV negative population is going to be increased, but in HIV positive population, it is going to increase about more than 4-fold. Again, if you look at people living with HIV in low and middle income countries and looking at different NCD prevalences in these individuals, you find cervical cancer, obesity, diabetes, hypertension, dyslipidemias, depression, and all these conditions coexisting with HIV. And basically, patients with HIV who have been on a long-term antiretroviral treatment are actually dying of non-communicable disease rather than HIV per se. Maternal health, again, it's an issue which is coming into the region. And this is again data from Tanzania. And you can see that in 1990, the gestational diabetes was almost unknown. And you find that in 2016, it is around 19%. So you can find that there has been an evolution which has taken place, and this is mainly related to the lack of physical activity, excess weight, and the dietary factors. And why maternal health is important? There is a component of what we call as a maternal health and NCD interaction, undernutrition and overnutrition, basically resulting into what we call as an intrauterine fetal growth. And intrauterine fetal growth, as this child grows up, there is a component of what we call as their susceptibility to get non-communicable disease is very important. So if we have to start any primary prevention needs to start from the antenatal clinics, where we make sure that those children who are born with a normal weight. Adolescent health, again, is a major issue, and I think it is an evolving issue currently. And if you see from the WHO Global School Health-Based Surveys, which have been done in 2015, in Burundi, in East African countries, Burundi, Kenya, Rwanda, Tanzania, Uganda, Ethiopia, and Zanzibar, you find that again, we are sitting again on a high burden of risk factors there in this adolescent health. And as these adolescents grow, the disease burden is going to increase. In addition to this disease burden, also you are finding that adolescent mental health problems, a diagnosis is also much, much more now. And you find that in different groups, depending on what type of a mental disorder you are talking about, you are talking about a mental disorder of anywhere from about 10 to 30% in these adolescents. Ncds in women, again, Ncds in women in Africa, we have got these risk factors, and this is basically a group which we need to really follow up and to see, because that becomes a very high burden component, a high burden group. And the risk factors include physical inactivity, tobacco use, alcohol, unhealthy diet, urbanization, increasing in life expectancy, poverty, indoor air pollution, and negative psychological effects due to widespread oppression and violence against women. And the burden actually is quite high. And if you look at the prevalence of diabetes among women in African region in 2017, again, you find in North Africa, West Africa, East Africa, Central and South, you find that there is a variation of the prevalence of diabetes. Similarly, if you look at the cancers among women, you find the breast cancer is again number 1, cervical cancer number 2, other neoplasms and ovarian cancers are number 3 and 4. And then again, the most important is basically the prevalence and incidence of mental and neurological disorders in Africa. And again, you find that mental disorders in male and female, again, the prevalences are very high and the numbers are very high. Similarly, neurological disorders also are quite high. Ncds and COVID, I think most of us have gone through this. And with the COVID, there has been an exacerbation of Ncds. And with the Ncds, there has been a high mortality and morbidity of patients who had a comorbidity with Ncds. And this is something which we need to look on any emerging pandemic which comes. People with non-communicable disease who are poorly controlled are going to be very susceptible. This is a WHO data which shows that of 136 countries reported that NCD services were disrupted during COVID crisis, and all these NCD services included diabetes, cancer screening, hypertension, asthma, cancer, dental care, and cardiovascular emergencies were affected due to some reason or the other. And in most of the cases, there were more than 50% were affected all across the region. Coming to governance, I think policy action by Africa, there's been WHO strategy on NCDs in Africa, which was updated in 2000 Ouagadougou and updated again 2010, Brazzaville Declaration, and then we have got multiple other meetings which have been held and different strategies which have been put in place. But again, if you look at the prioritization of the NCDs in the region, and if you compare them with the other regions of the world, I think we are still lagging behind in health plans, development agenda, targets, and indicators. And again, looking at different over the period of time from 2010 to 2019, all the NCD surveys have shown that we have been on a trajectory of an increase. Human resources for health, that's our major challenge. And if you look at the global distribution of the health workforce, you find that African region, which carries more than 25% of the burden of the global burden of disease, you find that the human resources for health is less than 5%. So you find that that is our major challenge which we have. And again, if you look at this data, which shows projections from 2013 to 2030, and if you look at the number of physicians, nurses, and other cadres which we are going to have, and the proportion per patient, again, we are lagging far behind with human resources for health. Once we have human resources for health, this is again data from Tanzania, which shows that what is the preparedness or what is the training given to these healthcare providers to manage this communicable and non-communicable disease at the primary care. And if we are going to use primary care as our center or nucleus for managing non-communicable disease, adequate training needs to be provided to these healthcare providers. Health financing, again, this is a data from Tanzania. A general sickness diminishes the household income by 7.6%, and Ncds deplete income by more than 53%. And most of the households get impoverished around 68% when they have somebody with NCD in the family. So it has got a huge effect on the costs. Again, if you look at the availability of the oral drugs, and if you compare with number of days of wages, you find that a simple drug like glibenclamide or metformin for diabetes, it consumes around 4 to 5 days of wages of a minimum worker, minimum salary. You find 5 days of that, it goes for a month's purchase of medications. And if you look at the catastrophic health expenditure in Africa, you find that the catastrophic health expenditure varies from 0.2 to 54.2%. And that is a huge sort of a spectrum in the entire African region, with most of them catastrophic expenditure between 5 to 10%. When you look at out-of-pocket expenditure on healthcare in developed versus developing nations in Sub-Saharan Africa, again, you find in developed countries, out-of-pocket expenditure varies from 10 to 16%, while in the African region, it varies from 53 to 76% as an out-of-pocket expenditure. Supply chain is a major problem, and I think at the end of the day, you can have the best system in place, but if your supply chain is poor, then things will not happen on the ground. And it requires competency. It requires competency at different levels regarding the medicine provision, use of medicine, medicine therapy assessment, and comprehensive medicine management plan. And you need to have appropriate protocols in place if you want to really make sure that your supply chain goes to the last mile. This is a median availability of generic medicine in a sample of health facilities in WHO Afro region in 2001. And you find that most of the countries in Sub-Saharan African region had less supply of medications, less than 20%. Again, this is data from Kenya, whereby you find that you expect the free medicines to go to the poor people, but you find from this data, medicines, metformin, salbutamol inhaler, and hydrochlorothiazide was going to the richer people and less to the poor people. And you find that there was this was a sort of a dischrony there. Again, if you look at the essential medicine distribution of Ncds, and this is the SARA survey from Uganda, you find that about 40% of the facilities basically did not have any essential non-communicable disease medicines, and you find only around 4 or 6 had some degree of medicines there. If you look at the supply of, again, compared to insulin and non-communicable disease drugs and availability, it is varying from 40 to 60%. Looking at the service delivery, again, service delivery, you find that there's an improvement of the service delivery from 1990 to 2019. There has been, we have moved from 35.6% to 55%. Definitely, there has been a significant improvement of the service delivery, but we need to work much, much harder to go to beyond 70, 75%. Again, WHO data shows that only 34% of the countries provide drug therapy and counseling services for cardiovascular diseases. Only 40% of the countries provide palliative care. Only 48% of the countries have guidelines for 4 major diseases. 62% of the countries have early detection program for cervical cancer. And you find that, again, treatment of cancer, again, is a major challenge. And if you look at this treatment cascade for 2 major chronic non-communicable diseases, one is diabetes. You look at the end of the day, out of the 100 patients who are expected to have diabetes, you find only 50% get measured, 37% are aware of their diagnosis, 17% receive advice, and at the end of the day, 11% only. So 11 out of 100 receive medication. And of those 11 out of 100 who receive medication, around only 2 or 3 are well controlled, while 9 are not poorly controlled. So you find that treatment cascade, and it is the same repetition from the data which was there again in 2015, that if you look at prevalence of hypertension of 30%, only 27% of those are aware, 73% are not aware. And of those who are aware, only 18% are treated, while 72% are not treated. And of those 18% who are managed, only 7% are controlled, and around 93% are poorly controlled. So there is something wrong which is happening in the sense that, one, simple conditions like diabetes and hypertension, which are bringing about huge amount of complications to eyes, kidneys, heart. If we are able to manage this well, then we will basically reduce the flow down the line. What have been the challenges? One is the access to care. Long distance is the cleaning. Opening hours are limited. There's a lack of qualified healthcare providers. Availability of essential medicine is a major challenge, and affordability of the care, as I've shown you, is a major challenge. And what is the underlying basic issue? If you look at the underinvestment in non-communicable disease, and if you look at this chart, you see maternal and child health is very well funded, HIV is very well funded, malaria funding is there, but if you look at the NCD funding over a period of time, it has hardly moved. There is no funding on NCD. Again, if you look at the overall financing and the disease burden, and if you look at the disease burden of Ncds and you look at the disease burden of HIV/AIDS, you find that Ncds basically is receiving only 0.7 billion in 2019 compared to 9.5 billion for HIV/AIDS. So there you can see the dichotomy. Again, if you look at the Abuja Declaration and if you look at the African region, you find only there are 5 countries which have crossed the Abuja Declaration requirement of 15%. More than around 60 to 70% of the countries have still are hovering between 6 and 10% of the Abuja Declaration. The global response currently, as you know, most of you must be knowing, this is from year 2000 to 2030. There's been a lot of initiatives which have been taking place at the global response, and there have been 9 voluntary NCD targets which we have to attain by 2025. And looking at the data set, you find that most of the countries in Sub-Saharan African region have not even attained 50% of those data sets or those global targets, which we are supposed to be reporting in 2025. So we have a lot of work to do. And again, we have this global monitoring framework with these 25 indicators, which is basically being monitored for these global targets. What is the way forward? One, we have to have an effective NCD service. We need to leverage. We need to decentralize, go to the primary care. We need to optimize the integration of the services where the services are already existing, and we need to optimize clustering of the related services. We need to change the way we look at the chronic disease model. The current view where we were mainly most of our health facilities were tuned to manage acute conditions. We now have to move to chronic conditions. And chronic conditions basically is a long-term condition. It is communities need to be empowered. People with the disease need to be empowered. It has to be team-based. It has to be continuous care. There has to be a predominant of preventive care there. Patients should be a partner. Self-care and self-management should be encouraged. And the carrier support should be as partners. And it requires high technology. So there are 8 critical points which have been built by Ncds to basically improve. This is inclusion of people living with Ncds in whatever you do. Humanitarian emergencies, how do you basically manage Ncds when you have humanitarian emergencies? Inclusion of Ncds in the primary healthcare, inclusion of Ncds in universal healthcare, international financial instruments, and looking at innovative financing for Ncds to fill those gaps which you have, working with the partners, closing the data gap, which is the major burden, because looking at the data, if you want to have a reliable data is not available. And we need to basically prioritize. We need to prioritize at the primary care level. We need to learn from the programs which have been very successful, HIV, TB, malaria program, maternal and child health programs, and we need to work as partners with different stakeholders. And best way basically is ensuring that the people are empowered. The global NCD, basically WHO has just released what they call as basically best buys. And if you are able to just implement those best buys, and if you are able to put in the appropriate policies and regulations in place regarding the best buys, then I think for every dollar invested, there's a return of $7 for that investment which you do. And these are very simple measures looking at tobacco control, salt reduction, physical activity, and diet. And that makes about a huge change. Again, climate and environment, as was mentioned by the Honorary Commissioner previously, I think we are moving towards a stage whereby environment and health is going to be an important component in NCD. And if you look at, there is already a scorecard, and this is a scorecard for Kenya. And this has been basically looking at NCD and looking at the environment and what environment and what severe environment. And based on this scorecard, for each country, there's an evaluation which is being done, looking at health impact, health in adaptation, health co-benefits, economic and finance, and total score. So if you see, Kenya has scored around 5 out of 15 in the health scorecard, which is basically something which is just starting. And I think we, as we move forward, environment and climate is going to be a very important component. And we need to basically, today we are spending most of our money in secondary and tertiary care and almost negligible in primary care. I think we need to shift that curve, and we need to spend more money in primary care, then followed by secondary and minimum at tertiary care. And if we want to achieve that, I think we need to shift. Universal health coverage is another area which is coming, it's big on the agenda. I will just go to last 3 slides, Mr. Chairman. Looking at the index of the universal health coverage and its coverage in 2015 and 2017, and you find that if you look at this shadow in the African region, I think it is only 1 or 2 countries in North Africa who have achieved around 78%, while you find most of the countries are at 51%, but majority of the countries in Sub-Saharan Africa are between 20 and 40% of that index of UHC. And basically, if you want to implement UHC, the health system supply side challenge needs to be improved. The governance and accountability of the health system needs to be improved, and the demand side also needs to be looked at. Thank you very much.
Excellent presentation from a global expert in the field of non-communicable diseases and injuries. I will not try to summarize what he has said because it's fully loaded. We moved through the burden to specific issues, which I'm really happy because they speak to the strategy that we've developed. And for instance, Prof talked about the supply chain disruption, which we've seen. And we know that Africa CDC during the COVID-19 pandemic championed the fact that Africa should not run out of supplies and really went the extra mile to supply member states. But again, now setting up a supply chain platform, the Africa Medicine Supply Platform, which we are looking at to see how we can take advantage of that in the supporting member state for non-communicable diseases and mental health. But again, Africa CDC is pushing member states to start producing some of these things locally. Local manufacturing is a big issue that is one of the biggest issues for the Director of Africa CDC, learning from the what you talked about, the COVID-19 disruption. So all of these we have fashioned into what we've done. Professor, thank you so much. We will take questions at the end, but maybe one burning question, if there is, we can take. If not, we wait till the end. Thank you. So the next presentation will also come from another expert in the field of non-communicable diseases, injuries, and mental health. This time around, we have a professor of psychiatry from the Ahmadu Bello University in Nigeria, Kaduna, Nigeria, Zaria. Professor Tawush Latif Sheikh is the National Secretary of the West African College of Physicians, a former president of the Association of Psychiatrists in Nigeria, and today he'll be talking to us on developing policies to address the increasing burden of mental ill health on the continent. Over to you, Professor Sheikh.
Thank you. Your Excellencies, Honorable Commissioners, Honorable Ministers, the Director General, Africa CDC, delegates here, I thank Africa CDC for giving me this rare privilege and honor to address the delegates here today. I'm talking about developing policies and legislative framework. The cursor is not moving. Hello? It's not moving. Use this one. Back. This one back. This one forward. Okay. So I'm talking about developing policies and legislative framework to address the increasing burden of mental health in Africa. But I'm sharing Nigeria's experience here today. So what I'm going to talk about mostly is about my experience as a mental health worker in Nigeria and a teacher as well. This is my outline. I will introduce to you, give you a background, the state of mental health in Nigeria, what we mean by governance, and what's our way forward. I'll try to be very brief, but that does not actually reduce the magnitude of the burden of mental health in Africa. We're Africans, so I want to start with a quotation from our elders, which is normal in Africa. I'm looking at quotation from the Director General of WHO, who is an African also. This thing keeps moving. It's on autopilot, kind of.
Maybe press just once.
Yes, I don't press on it, just it will go.
Then it will come back.
Okay. So I'm taking this from Dr. Tedros, the Director General of WHO. It's moving. Yeah. You see, it's just going.
Can you stop sharing then? We...
It's on autopilot, kind of.
Where is it? This? This one? Sure.
Okay. It's going to be on the Still moving. So I'll just be dragging it back.
Yeah.
If it moves, I'll pull it back. That's what I'll do. So the world is accepting the concept of universal health coverage. Mental health must be an integral part of universal health coverage. Sorry, this is going to be tedious. I thought I would be able to be dragging it back, but it seems it's...
Yes.
Yes, I think that would be okay. Just leave it on PowerPoint.
Yeah, you just leave it like this.
It's readable.
Yeah.
Like this? Okay. Hmm?
Yeah, there should be animation. Yeah, but hold on, see if it will not move. You see, it's still
Okay. Let me.
It's done now. So share. Yeah. So remove it from full screen. Share it like this. Share it like this. Share. Go ahead and share. Oh, okay, was it shared already? Share. No. Stop sharing. Yeah. Where is it? This one? I just leave it like that. No, don't put full screen. Yeah, just leave it like that. Leave it like that. No, if you put full screen, it will still remove it from full screen. Just leave it like this. Leave it like this. That's it. Can you collapse this? Okay, collapse that one.
Apologies for the technical issues. It's technology. All right. So I'm taking this from the DG of WHO, who said that the world is accepting the concept of universal health coverage. Mental health must be an integral part of universal health coverage. Nobody should be denied access to mental health care because she or he is poor or lives in a remote place. And we know this is applicable to us in Africa. I'll go on to also quote from the WHO Special Initiative for Mental Health. And it says that the time to act is now, to empower communities and individuals to attain the highest standard of health, which can only be achieved when their mental health and well-being is ensured and their rights respected. The vision of the WHO Special Initiative for Mental Health is that all people achieve the highest standard of mental health and well-being, which means mental health is also synonymous with human rights. Your right must also be part of it. Now, what do we mean by social determinants of mental health? These are societal problems that disrupt optimal mental health, increase risk for and prevalence of mental illnesses, and worsens outcomes among individuals with mental illnesses. Mental health and many common mental disorders are shaped to a great extent by the social, economic, and physical environments in which people live, including climate change. Social inequalities are associated with increased risk of many common mental disorders. We want our leaders to understand this, to understand what is behind mental health, so that when we talk to them, they will know where we are coming from. And that's why I'm bringing out these social determinants of mental health. Now, what's the background of mental health in Nigeria? It is estimated that about 20 to 30% of Nigeria's population at some time in their lifetime will suffer from mental health challenges. Common mental disorders we encounter every day include anxiety, depression, psychosis, substance use disorders, mental disorders in pregnancies and childbirth, childhood psychological and developmental disorders, deliberate self-harm, suicide, just to mention some. How does the Nigerian mental health system look? The Nigerian mental health system lacks provision for targeting actions to tackle the precise needs of groups who have been historically neglected, such as women, children, elderly, homeless, and the very poor. Such specific focus is necessitated by the likelihood of these groups having different risk factors, mental disorder prevalence, and help-seeking behaviors. There is no clearly defined budget allocation for mental health in the national health budget of Nigeria. Only a paltry sum of 3.3% of the health budget of the central government goes to mental health. 3.3% of the health budget. The health budget itself is getting less than 6% of the total budget of the country. So you can imagine what that comes to. Over 90% of this amount is going to institution-based services provided through 8 standalone mental hospitals that we have in Nigeria. There is enormous inequity in the distribution of mental health services and available resources as compared to physical health in Nigeria. So when we talk about access to mental health care in Nigeria, what do we mean by that? Access deals with awareness, it deals with availability, and it deals with governance. And when we talk about awareness, we talk about awareness of the existence of the problem itself. Do you know that mental health is an illness? And this cut across Africa. We also talk about awareness of where you can go if you have a problem. We also have this problem in Africa. We know that. And then, do we have available services? Do we have institutions, human resources, medications, national health insurance, the purchasing power of people? And of course, they all sit on governance. And the way I put it, if you move that governance out, every other thing collapses. So everything sits on what policy or legislation that you have on the ground that will be able to guarantee access to mental health care. So I'm picking awareness again. Mental health is now considered one of the most neglected areas of health, both in Nigeria, in Africa, and the world. Poor awareness to mental health is usually driven by misconceptions, by myths, and stigma. Studies have shown that over 70% of patients with mental health problems seek unorthodox interventions before they come to the orthodox clinics. And we do know that health-seeking behavior for common mental health problems is determined by, to some extent, stigma. People look right, left, and center before they enter a neuropsychiatric facility. They want to check whether their in-laws are watching them, whether their enemy is close by. They will go and report that I've seen such person going to a mental health facility. Availability of mental health services in Nigeria. In Nigeria, mental health is the 9th component of primary health care service, following the Alma Mater Declaration. However, we have 8 standalone psychiatric hospitals. We have mental health services being provided by university teaching hospitals. But we have not been able to integrate mental health into primary care, and we do not provide significantly mental health services at secondary health care facilities. Nigeria has a ratio of mental health bed of 10 per 1 million persons. The treatment gap. The number of serious cases receiving no treatment during the last 12 months in developed countries varies from 35 to 50%. This treatment gap in Nigeria is as high as 85%. And this is referred to a mental health gap. And we know what this means. Human resources. There are less than 300 psychiatrists in Nigeria today, and most of them are located in state capitals. Remember, we are about 200 million people that have been serviced by 300 psychiatrists. You'll know where we're going later. We have the same problem with clinical psychologists, the same issues with psychiatric nurses. The ratio of psychiatrists in Nigeria to 100,000 persons is 0.09, and the ratio of psychiatric nurses is 4 per 100,000. The ratio of clinical psychologists is 0.02 by 100,000, and social worker, the same, 0.02 to 100,000. Human resources versus training. As far back as 1970, we had about 35 psychiatrists in Nigeria and about 400 registered psychiatric nurses. Our population then was less than probably 100 million. Almost all of these 35 psychiatrists were trained in UK. And there was a projection that by 1985, we would be able to satisfy a ratio of 2 to 1 million psychiatrists to the population of Nigeria. Today, we are still less than 1 to 2 million people. Today, about 300 psychiatrists we have 300 psychiatrists in Nigeria and over 1,000 Nigerian psychiatrists outside Nigeria. You can see the contradiction there. So something is going on. And we refer to this as brain drain because we have institutions that are training psychiatrists. We have the National Postgraduate Medical College. We have the West African College of Physicians. We have post-basic training institutions for nursing. And as soon as you produce them, it is a visa for them to move to the developed countries. These are the challenges that we are facing. The issue of medication, health insurance, and funding. Some basic psychotropic medications are on the list of essential medicines in Nigeria, but they are not always available at the health centers, and mostly they are outdated. You still find chlorpromazine all over the place. Health financing in Nigeria is typically out of pocket, which we consider a dangerous and potentially catastrophic system. It lacks equity and limits healthcare delivery. It also makes cost of care prohibitive due to both direct and incidental costs. You abandon your job to escort somebody, you borrow money to take somebody to the hospital at a very high interest, and so on and so forth. Now, you heard me talking about governance, and I told you that once I remove governance, every other thing collapses. Why is it so? Mental health system of a society relies on the existence of robust governance structure. Where there is deficient or absent, where this is deficient or absent, there cannot be effective and sustainable program. Regardless of the amount of funds that you pump into the program, either direct budgets or donor grants or both, it will not be meaningful because it will not be sustainable. Governance is a measure of the political will of the society. So a society that does not have a robust governance system on the ground for a program is not ready to really tackle that problem. That is what it means. Mobilizing for systemic change and better mental health care relies on mental health governance structures of the country, which are policy and legislation framework. What do you mean by policy? A commitment to its people by the government. If I have money, I'll do this for you. It is not a law. A father can tell his son, I'm going to buy a shoe for you during Salah. And then the sister falls sick. He takes the money that he will use to buy the shoe to take the sister to the hospital. That's a policy. Nobody can charge him. Whereas legislation is an enforcement that will compel the government to fulfill its promise to the people and protect the mentally ill. So if you carry the money you use to buy me a shoe to take my sister to the hospital, then a law will compel you to borrow money to buy me a shoe. You have to fulfill it. So that is the relationship between policy and legislation. And where these two do not exist, then we are not ready. Nigeria Mental Health Service Delivery Policy. The Mental Health Service Delivery Policy is a document of 1991, which was developed 31 years after our independence. That was the first document. It was revised in 2013. I happened to be a participant at the revision of this document. And it's actually has a placement of provision of mental health services at the primary healthcare level, integration through tax shifting. It is yet to be fully implemented. It's still gathering dust on the shelves, and it is due for review, and it doesn't have a matching strategic plan, no responsibility. Who will do what, where, when, at what cost, and who will check whether it has been done correctly or not. That is the strategic plan. It is not matched by it. So we are really not ready to fly. That's what it means. The vision of the policy states that the government and people of Nigeria hereby reaffirm that health, including mental health, mental well-being is the inalienable right of every Nigerian. And mental, neurological, and substance abuse care shall be made available to all citizens within the national health system at primary level, at level of primary health care and in communities. You see what we mean by promises? You make promises, but how do you fulfill it? The mental health policy is hinged on mainstreaming mental and neurological health within national health, social welfare, education, and criminal justice policy, integrating mental and neurological health into primary care and decentralization of specialist mental and neurological health system. After all, we don't have enough. Strengthening and developing existing systems for health resource development, health information, and communication. So when we look at it, we'll now be able to justify why do we need to integrate mental health into primary healthcare system. First, substantial proportion of people with mental health conditions do not get appropriate treatment. That is true, it's a fact. There is need to address the mental health gap, which is about 85% for Nigeria. Traditionally, neurological and mental health services have been concentrated in tertiary care hospitals, the standalone neuropsychiatric hospitals, and teaching hospitals. Large segments of the population, particularly those who live in rural and remote areas, have been deprived of such services. This is despite the fact that mental health conditions are common in rural communities. Now, what about mental health legislation? Mental health services in Nigeria continue to toil under the legacy of colonial mental health laws. What we are using in Nigeria today is the Lunacy Act of 1916. And I'm sure sister African countries share the same. This is an act that is seeing mental health and mental disorders the way it was being seen in 1916. There is nothing called mental health in that act. Nothing. It's all about lunacy, asylum, and so on. It had the status of an ordinance, but gradually became the framework for regional laws. It attained the status of a law in 1959 with its clearly colonial orientation intact since commencement. We try to review the current mental health law. Sorry, good. Using the guideline for mental health legislation, WHO 2005. And this is what we found, that the current mental health law lacks focus on human rights and non-discrimination. It lacks access to services and lists restrictive treatment alternatives. Its definitions are inadequate in humaneness and scope. It continues to employ denigrating terms such as lunatic, idiot, and unsound mind, focusing almost entirely on custodial care and asylum. It fails to define mental disorder or mental disability or even substance abuse disorders. It's unable to adequately provide for mental health care on equal footing with physical health. It gives no attention to mental health care financing or access services within primary care settings. It provides no direction as to the issues of consent or privacy or confidentiality. It makes no mention of the rights of families or carers of the mentally ill in relation to right to information and at and during admission, right to appeal, involuntary admission, and etc. Finally, it failed to specify the criteria for potential harm to self or others as a core basis for involuntary admission. What the Lunacy Act says that anybody that I point to that this person has mental illness, send him to the asylum. That's all, custodial care. So we gathered ourselves together and we packaged a draft mental health bill. And for 4 years, I've been the one that has been leading the group that has been pushing for a reformation of the mental health law in Nigeria. So we call it the Nigerian Mental Health Bill. Thank God it is currently before the president, and we hope that Africa CDC will also help us to push the president to sign it into law. Did you, sir? The opening of that bill is that a bill to establish a mental health department and promote and protect the rights of persons with mental health conditions and persons with intellectual, psychosocial, or cognitive disabilities, and to provide for the enhancement and regulation of mental health services in Nigeria. The key objectives of the bill are: 1, provide direction for a coherent, rational, and unified response to the delivery of mental health services in Nigeria. To promote and protect the fundamental human rights and the freedom of all persons with mental health, intellectual, psychosocial, or cognitive disabilities conditions, and ensure that their rights are guaranteed. Ensure a better quality of life through access to an integrated, not standalone hospital, not standalone psychiatric hospitals, integrated, well-planned, effectively organized, and efficiently delivered mental health services in Nigeria. To promote the implementation of approved national minimum standards for mental health services in Nigeria. To promote recovery from mental health conditions and enhance rehabilitation and integration of persons with mental health conditions, intellectual, psychosocial, or cognitive disabilities into the community. To facilitate the adoption of a community-based approach to the provision of mental health care services and facilitate the coordination of mental health services delivery in Nigeria among the activities. Now, that is what we have in the package of the mental health bill. Of course, it's much more than this. I just took out key aspects of them. In the course of ensuring that this bill is passed, we engage in a lot of activities which included advocacy, awareness, partnerships, and engagements. And I have a pictorial here, just about 3 or 4 pictures to show what we did. We had a 3-day mental health stakeholders meeting at Yaba, and we could see Professor Gureje here. He's the father of psychiatry in Nigeria today. Everybody knows him, probably in Africa. Past president of Association of Psychiatrists in Nigeria. And Professor Adeyemi is also a past president of Association of Psychiatrists. And then we were there on the table working, chaired by Professor Gureje. And here we are, a closer look. And then the Federal Ministry of Health and our partners, CBM, WHO, everybody was here. We had a Mental Health Action Committee meeting, and it was to finalize the draft mental health bill. Everybody's there. Our picture there with Gureje in the middle. Florence Ghana is there. Everybody is there. And then this is a meeting of stakeholders with the Federal Ministry of Health and WHO in August 2019. All of us are there. And a closer look here. And here we are. And this is the hall. A lot of work going on. And this is our WHO regional representative. And this is an expert on CRPD to look into the human rights aspects of the mental health bill. And this is the then permanent secretary, Federal Ministry of Health, and the directors in the Federal Ministry of Health. And we carried everybody along. We hope it will come. So where do we hope to be? We want the passage of the mental health bill into law in Nigeria. We want a revision of the 2013 National Mental Health Care Service Delivery Policy. And we also want to develop a matching national strategic plan for mental health. We hope there will be some sort of increase in mental health funding through direct budgetary allocation and indirect allocation by integration of mental health into primary care. So in conclusion, mental health has come a long way in Nigeria, but we are yet to achieve the systemic change for universal access to effective, qualitative, and affordable mental health care due to poor governance structure for mental health. Strengthening mental health governance among African countries by Africa CDC is a rate-determining step towards achievement of universal health coverage for Africans. So I want to acknowledge Professor Gureje. I want to acknowledge CBM, Julian is there, Johnson & Johnson, Pharma, National Mental Health Action Committee, all the people of the Federal Ministry of Health, the directors are here, and the coordinator for mental health is here, WHO, and my university, and our alma mater. I thank you very much for listening.
Thank you so much, Professor Sheikh. Another excellent presentation, focusing this time around on the primary role of what Africa CDC should be doing, which is supporting member states. And his presentation really showed how the roadmap to getting a national mental health bill were essential for strong show in the member state. One thing, there are some themes that are coming very clearly, even the last two presentations: health financing, tertiary, secondary care being prioritized against primary health care, health equity. But Professor Sheikh talked very eloquently about the workforce development on the continent and the brain drain. This, in my thinking, is a clear and present danger for the continent. In the hospital where I used to work, in the last 3 months, more than 40 neuropsychiatric nurses have left that just one hospital, and half of them going to the United Kingdom and other European countries, and of course, in Saudi Arabia. So that is a serious problem. But I want to say that Africa CDC is taking workforce development very seriously. In fact, it's one of the cardinal points of what the director talked about early this morning when he talked about the new public health order. Workforce development is what we think will help us prepare for the next pandemic, and Ncd's mental health may just not be the next pandemic, if you are so to speak. But let me say, we are working at the highest level, working with the president of South Africa on what we call the health task force, tax team for workforce. And these are being addressed. We'll continue to see how we can address it so that the workforce on the continent can be very beneficial to the continent. Thank you, Professor Sheikh. We will now go to the next presenter will be online. And it's from the UN Multi-Partner Trust Fund for Ncds and Mental Health. I think we have Dr. Mamka online. Dr. Mamka, can you confirm you're online?
Yes, I am here. Are you able to see and hear me?
So please take the floor. You can introduce yourself fully and then start the presentation. We can see your slide already. Thank you. Over to you.
Okay. Thank you so much. I can hear an echo. I don't know whether... No, that's so much better. So I'm Dr. Mamka Anyona. I am the lead for policy and strategy at the UN Multi-Partner Trust Fund for Ncds and Mental Health. The trust fund is hosted within the UN Interagency Task Force for Ncds and Mental Health, which is hosted by the World Health Organization. So first of all, I would like to thank Africa CDC for the invitation to this validation and launch of the NCDI and mental health strategy. It's unfortunate that I was not able to be there with you personally, physically, because there was a significant scheduling conflict that required me to be here. But I'm joining you virtually from New York City, where it's 5:15 a.m. in the morning. But I have really enjoyed listening to all the speakers who came before me and really putting into context the challenges ahead of Africa CDC and the rest of us in NCDIs and mental health. I would also like to congratulate Africa CDC on the incredible progress that has been made since you were founded just a few years ago, and also to congratulate you on this significant milestone of launching this strategy that is going to support member states to achieve the global and national targets for NCDIs and mental health. So the subject of my presentation today is on the global efforts for partnership and multi-sectoral action for NCDIs and mental health. And it is highly relevant to where I sit within the WHO and in the UN system generally, and therefore quite appropriate. And it's a subject that will be very critical to the success of Africa NCDI strategy. So first slide, please. Next slide, please. Great, thank you. So multi-sectoral action is a key component of NCDI and mental health prevention and management. And a lot of the policy and other critical interventions that are required to achieve success and to achieve the global and national targets, their implementation lies outside of what would be considered the traditional health sector, especially when you think about prevention. So for example, when you're ensuring that populations have access to healthy diets, you are required to work very closely with the agricultural sector. You are required to work with municipalities and local governments to ensure that city planning takes into consideration access to food. And when you're thinking about planning for food security, we also need to be thinking about climate and the planetary health considerations and working with the relevant sectors. When you think about tobacco control policies, the development of legislation lies entirely outside of the health sector and requires you to work closely with parliamentarians. The enforcement of regulations is conducted often by local governments, and so on and so forth. And even when you think about the more health system related and service delivery requirements for NCDIs and mental health, you're also required to think to be working very closely with other sectors. So for example, when you think about essential medicines, supply chain strengthening requires that the health sector decision makers work closely with trade and customs and infrastructure and other sectors. And then beyond engaging with within the government across sectors, we also have to think about working with non-state actors, and that is other stakeholders outside of the state. The private sector is an inescapable sector with which we have to engage, and we have to differentiate, for example, when you're dealing with the private sector, between those with whom we want to cultivate mutually beneficial partnerships and those with whom we need to work to regulate for prevention for management of NCDs. So in addition to the importance of working with the private sector, we also need to work with civil society. We need to work closely with NGOs, global and national. We need to work with academia. We need to work with affected communities and involve them in the design of policy and in the monitoring and holding the government accountable to the policies that to policies and legislation that they have signed on to for NCDs and mental health. So this profound importance of multi-sectoral and multi-stakeholder collaboration has been voiced explicitly by the various bodies that govern global health and govern the frameworks and resolutions for NCDs. So the UN General Assembly, ECOSOC, the World Health Assembly have all come out strongly recommending and providing resolutions around multi-sectoral action. So for example, the political declaration at the third high-level meeting on prevention and control of NCDs, it says that governments need to address a broad range of social, economic, and governance issues through multi-sectoral action. And then the WHO's Global NCD Action Plan that was recently extended to 2030 also requires that effective NCD prevention and control requires leadership, coordinated multi-sectoral and multi-stakeholder engagement, and across a broad range of sectors and partnerships with relevant civil society and private sector entities. The SDG 3 GAP, which was launched in 2019 as a non-binding agreement between 12 international organizations on better collaboration and cooperation for health and development, also centers multi-sectoral action for NCDIs, including for NCDIs and mental health. So within the WHO, there are a number of platforms that are dedicated to providing support for multi-sectoral and multi-stakeholder engagement for NCDIs and mental health. So the Global NCD platform is a department within the WHO headquarters, and it is tasked with this obligation and consists of two platforms primarily. So there's the Global Coordination Mechanism and the UN Interagency Task Force for NCDs. So the Africa NCDI strategy, which we are happy to see, is built around these two pillars of multi-sectoral action and coordination, is very well aligned with these global targets. It is well aligned with WHO, with WHO's mandate. It is well aligned with the global NCDs platform and the approach for multi-sectoral action. And the rest of this presentation is going to go into greater detail on the mandate of these two of the global NCD platform And we'll finish off by proposing specific entry points for future collaboration with Africa CDC. And of course, we also invite, other member states who are in attendance today, development partners and others to also engage with these resources within the global NCD platform at the WHO. Next slide, please. Next slide, please. Great, thank you. So the global, so we'll start off with the global coordination mechanism. This was established by a mandate of the member states in 2015, and this mandate was extended at the 2021 World Health Assembly to 2030 to align with the SDGs. So the GCM plays a key role in promoting, enhancing, and enabling multi-sectoral and multi-stakeholder responses to accelerate progress towards global and national NCD targets. So the GCM works with state actors and non-state actors through inclusive and participatory dialogue and consultation, knowledge sharing of best practices, and working on effective multi-sectoral and multi-stakeholder approaches. So the GCM basically works by facilitating collaboration at national, regional, and global level between actors, between the stakeholders for NCDs, including state and non-state actors. So next slide, please. So I will go through a few of the activities that the GCM engages with. So the GCM has a knowledge action platform, portal rather, that was launched in 2018. And this portal is basically, it's an online platform for knowledge sharing and mobilizing knowledge resources and collaboratively acting across governments, NGOs, civil society, people living with NCDs and mental health conditions and affected communities. So this online platform has 2,600 subscribers, and it has a vast repository of knowledge resources such as guidelines, best practices, reports, policy briefs, and these are accessible to subscribers, and it's open for subscription. So I welcome everybody here to take the opportunity to browse through the Knowledge Action portal, and the Knowledge Action portal also hosts the Ncd Lab. So the Ncd Lab is basically a crowdsourcing of innovations around NCDs, and this the lab has been sourcing submissions from around the world on innovations around NCDs, and these are made available on this knowledge sharing platform for the rest of the world. The GCM also is developing a tool to support member states in decision making on private sector engagement. So this tool will support national governments, subnational governments to be able to design partnerships with, to evaluate and design partnerships with the private sector that are guided by informed decision making that take into consideration the conflict of interests and that are take into consideration as well the management of risks. And this tool will be launched and will be made available within the year, hopefully before the end of the year. Next slide, please. So the GCM also works on, is also putting together a repository of information on best practices for multi-sectoral action, and have actually launched a call for submission, inviting member states to submit, examples of best practices on how to conduct multi-sectoral action for NCDs and mental health. So again, we invite you, if you have any good examples, to go online, and I don't know whether we will circulate the slides, but there's a link where you can also submit cases that you're aware of, and then very importantly, recently the GCM has been working on a framework for meaningful engagement with people living with NCDs, and has been conducting consultations across regions, including one that was conducted very recently in Afro, and is going to develop guidelines for meaningful engagement in the context of policy design and implementation, monitoring, and so on and so forth. Next slide, please. So the second component of the global NCDs platform is the Interagency Task Force for Ncds, for the prevention and control of Ncds. This was also established through a mandate, but it was the mandate of the ECOSOC, and it was established in 2013 as one of the recommendations of the 2011 political declaration. And the task force was created to coordinate activity on NCDs across different UN agencies, but it was created with a dedicated secretariat that is based in the WHO. So the mandate is to bring together the UN system to ensure coherence and coordination across the agencies with regard to their policy and programming for NCDs. And the task force really focuses their work on country level and works through the UN country teams to ensure that there is enhanced collaboration and enhanced action on NCDs. So in 2016, the task force was expanded to include NCD-related SDGs. In 2018, to develop partnerships for public health goals, and in 2020 to include the COVID-19 response and recovery. Next slide, please. So this map shows the vast footprint of the work that the task force has been conducting across countries. And the task force basically advocates for whole of government and whole of society actions, and it supports countries to forge multi-stakeholder partnerships and alliances. And the task force achieves these goals through a number of activities. So it convenes biannual meetings of the more than 40 UN agency members. And it also convenes, joint programming, and through these joint programs, conducts missions in countries to support countries to tackle NCDs and mental health in a number of thematic areas. So, for example, one of the joint programs is on alcohol control through the Safer Partnership, which includes UN agencies and civil society organizations. There is a program on cervical cancer elimination through a joint initiative that includes 5 UN agencies, including UNFPA, WHO, UNICEF, IEA, and UNAIDS. And the task force also convenes some thematic working groups that provide thought leadership on specific agendas, for example, nutrition and the environment. And this map basically shows the footprint in terms of where joint programs have been conducted, where investment cases. That's another one of the actions, of the main actions of the Interagency Task Force, is supporting countries in developing investment cases for particular thematic areas within NCDs and mental health. And they have, and these have been conducted across a number of countries across the world. Next slide, please. And this particular slide shows the particular activity within the Afro region. So, for example, there's a NCD investment case in progress in Botswana. Kenya recently launched a mental health investment case, and there was a joint mission in Kenya as well in 2014. There's an NCD investment case that was done in Ethiopia. And there have been a number of joint missions as well for other joint programming. So, for example, Uganda is one of the countries where the alcohol control safer initiative is working, as well as a mental health investment case being conducted in Uganda. So this table just kind of shows you that there's a footprint across the region as well for the task force's work. Next slide, please. So one of the pillars of the task force's strategy is supporting global and country level resource mobilization to scale up NCD action. And the flagship initiative under this pillar has been the establishment of the UN Multi-Partner Trust Fund for NCDs and mental health. And this is the trust fund where I work, leading on policy and strategy. So the trust fund was established in 2020, May of 2020. So we're just about to hit our first birthday. And it was established as a collaboration between UNDP, UNICEF, and WHO, who are the lead UN agencies. But this is very much a one UN initiative. And as the first order of business when we came on board, it was to ensure that this initiative, this multi-partner trust fund, has at its core one of its pillars as well and principles, the centering of countries. And therefore, then we worked on getting commitments from 3 founding strategic partners, that is Kenya, Thailand, and Uruguay, who are some of the exemplars of NCD action at the global level. So the UN, so this UN Multi-Partner Trust Fund is, it's a country-led initiative. It is, and it aims to raise $250 million over a period of 5 years to provide catalytic funding to countries to increase the level of action for NCDs and mental health. So the ways in which this catalytic action is to occur is through stimulating whole of government and whole of society policy change and program action, and to support countries as well to increase domestic resource mobilization. So this fund itself is also a response to member state demand. Countries have demanded for the establishment of this, of such a mechanism through various activities over the past decade, and this is the culmination. Its establishment is the culmination of this country demand. So this trust fund will enable countries to unblock bottlenecks in the policy to action continuum, including supporting the establishment of governance and legislative and regulatory frameworks that are going to support countries to scale up their action on NCDs and mental health. Next slide, please. So to make this more concrete, what it is we mean by catalytic action, we have a set of examples here. So I will not go through them all in detail, but I'll just give I'll give some examples, such as, in one country, the task force, the trust fund may provide funding for legislation and regulation to promote healthy diet among children, and that will include a number of interventions that will be funded by the trust fund. The trust fund may also provide funding, for example, to another country to support the development of legislation and regulation frameworks for increasing taxes on tobacco and providing the relevant technical assistance for this type of regulation. So the trust fund does not aim to be the global fund for NCDs. It very much aims, because we acknowledge that model of health financing is not necessarily, as global health evolves, is not necessarily one that is going to be able to be replicated in the future. But we also acknowledge that there's a lot of work that needs to happen at global and country level to develop the requisite global public goods, and to support countries to overcome some of the barriers that are preventing action on NCDs and mental health, that are preventing these beautiful policies that countries have from turning into action. So this trust fund aims to provide that kind of catalytic support to countries. Next slide, please. So that is about the trust fund. So the GNP, that is the global NCD platform, has other activities under it as well. They provide an online training course on NCDs through the Johns Hopkins University. There is a project that's ongoing on integrating NCDs into maternal, newborn, and child health. There's publishing of a special on BMJ, again on NCDs and MNCH, and a number of other activities which we welcome you to browse online and to engage with by reaching out to the GNP. Next slide, please. So that was a bit of an overview of the global frameworks that exist and the infrastructure for supporting multi-sectoral action at global and national level. And so we invite Africa CDC to work with us. So for example, with regard to the trust fund, we invite you to work with us on advocacy, on joint resource mobilization. In this very constrained funding environment, it's going to be important for us to work together to explore blended financing instruments, and as well to explore ways in which we can synergize our activities to catalyze action at the global level. So for example, through market market shaping for essential medicines, and how it is that, and how we can work together at country level as well. So, for example, we make co-financing at country level. We can provide joint support to programming in countries as well. With the Interagency Task Force, we invite Africa CDC to participate in the biannual meetings so that you can have an overview of the activities across the UN system for Ncds and mental health, to join the joint programming missions that happen in the countries across the region, and participate in investment case missions as well. And in this way, continue to increase the collaboration at that level. And we also welcome you to engage with the working groups and the joint initiatives. For example, it may be very important to look into the joint work that is ongoing at the UN on health taxes that have become extremely relevant at this time in this post-COVID era, and may end up being a very critical source of global domestic resource mobilization. And there's other work ongoing as well that's very interesting around healthy diets and of course the Cervical Cancer Joint Initiative. We also invite you to engage with the Global Coordination Mechanism, and to very much make use of the resources within the Global Coordination Mechanism, including this vast network of NGOs, academia, private sector foundations, and all other actors who may prove very critical to the success of the Africa CDC strategy. We welcome you to subscribe to the Knowledge Action Portal and take advantage of the resources and knowledge products therein, and to participate in the activities I stated earlier, such as the consultations for people living with Ncds and mental health, and the multi-sectional action case studies, and of course, once it is published, to utilize the private sector engagement decision-making tool, which will be a critical tool to support countries to engage with private sector, who tends to, as has been said in other in some of the presentations before, who provide a lot of the services and are very critical in ensuring the success of Ncds strategies, but who we often do not engage with because we do not have, national governments often do not have the capacity, the technical capacity to do so. I will end this presentation here, and I thank you all for inviting me once more, and invite you to reach out to engage with us and Africa CDC as well as all other participants. Thank you so much. I'll invite any questions if they're there.
Thank you so much, Dr. Rosemary Mamka, from the Policy and Strategy Team Lead of the UN Trust Fund for Ncds and Mental Health. A really excellent presentation on the multi-sectoral approach to prevention and control of Ncds and mental health. And for Africa CDC, we know that WHO is our natural partner in everything we do, and the UN or other UN agencies, and that's why at the very beginning, some of the first documents that we reviewed so that we keep in mind aligning what we have here with is the UN documents, especially the WHO Global Action Plan on NCD prevention and control, and the Sustainable Development Goals, targets 3 and 4, 3.43 and 8, WHO Essential Public Health Function Framework, and many other documents were consulted, and we seek alignment with what we have today presenting to the member state. Africa CDC will definitely like to work with your team, Rosemary, and that's why we feel you should come here and address this August gathering of member states and ministers of health. Thank you once again for an excellent presentation. Now we are coming to the final presentation. Please, I would like to ask Rosemary to stay online, because we'll be taking questions immediately after the final presentation, and also to invite Professor Kaushik and Professor Sheikh to please return here, so that if any question is addressed to you, you can respond adequately. So It gives me great pleasure to invite no other person than the Deputy Director of Africa CDC, who has been really the high-level support that has made this possible. The fact that we are here today is because Dr. Ahmed has given us so much support. I'm not surprised because he has a strong background in non-communicable diseases, and he considers Ncds and mental health as his own. So we are really privileged to have Dr. Ahmed with us today to talk on the impacts from COVID-19 on non-communicable diseases, mental health, and lessons learned for the prevention and control. Dr. Ahmed, sir.
No, thanks a lot, Mohammed, and big thank you to all the former speakers who've given us a flavor of some very concrete things. And to follow up on that, I'll just like to tell Mamka that Africa CDC is going to reach out to the UN family in general, so we can be able to start some very early work in establishing early wins for this strategy, because the strategy has, as will be seen over the next 2-3 days, has some very concrete proposals that can fit in very well with the objective of the UN fund that has been set up there. So I would like to speak a little about the last 2 years, the lessons that we've learned, and how we can be able to bring that and adapt it into Ncds. And I hope that we can then be able to utilize the momentum that we have had, where health has been the focus of the globe for the last 2 years. I think it will still be a focus for a little while longer. And we need to ensure that we take good advantage of that focus. As we say in health emergencies, never waste an outbreak, never waste an emergency. And this COVID, we don't want to waste it. We want to be sure that we utilize that opportunity that it has created to ensure that many other parts, particularly neglected ones like Ncds, mental health, are appropriately taken into the priority list. So I'll divide my presentation into those 3 areas. And just to sit back and look at big figures. When we do projections for the global population, it is very clear that Africa is the growth area for the world in as far as population is concerned. And this has a lot of implications, not just for health and the economy. It has implications in every sector and every part of the way that we live. So when we have that at the back of our minds and we are seeing 1.3 billion people on the continent today, we need to be seeing many more billions in terms of lives that are going to be residing here on the continent. Meanwhile, as the numbers grow, urbanization is also increasing on the continent. And as previous colleagues, but particularly Kaushik's presentation that shows there's a very strong link between urbanization and Ncds. So as our population becomes larger and we become more urbanized, the problem we are facing now is most probably going to become larger if we do not do something about it in an effective and quick way. Now, when we look at the continent, many times when we speak about our disease burdens, we are largely speaking about communicable diseases. When we look at budgets, and I think the example from Nigeria was very telling, when you look at budgets, very small portions of our health budget is put into Ncds and mental health. very small portions of our national budgets are put into health. And the Abuja Declaration for 15% has really not been gaining a lot of traction on the continent over the last decade or so that particular declaration was passed. So when we look at emerging diseases like COVID, Zika, and the others that are creating tension around the world, when we look at the traditional endemic diseases that we've had, and now adding on that our Ncds, we have a mix, what we call syndemics. We have a mix that is very risky for the continent that is growing. And it is very risky in the sense that it not only affects our productivity, and economists like to see, and even policymakers like to see figures, and 800 billion is a big figure, but hidden under those figures are the long-term effects. When we have Ncds affecting younger and younger populations, and ours is very young, and when we have projections for DALIs showing us just how much of a threat these syndemics are for the continent. But when we focus on COVID as part of the syndemic we are facing on the continent, we see how strong a relationship that this pandemic has had with Ncds. We've seen the increase in mortality amongst those who have comorbidities with Ncds. We've seen the very high hospitalization rates when it comes to those who are suffering from Ncds. We have seen the disruption of our health systems. And when the health systems are disrupted and anything needs to be fixed, Ncds were not the first ones to be fixed. They are the ones that came later. We will chase the usual communicable diseases to fix first before Ncd becomes fixed as well. So in this way, not only did COVID-19 impact Ncds directly, it also had an indirect impact, whether it was mobility or mortality. And some of the ways in which the disruptions have happened have already been shared briefly, but our routine health services have not been sustained because our health workers are few and they've been very busy struggling to address the protocols that have been put in place for COVID. We have seen that the disruption in the supply chain has meant that medicines are now not being effectively distributed onto the African continent, and then from there on to the communities. Indeed, because we manufacture very little of what we consume in terms of medicines, it means that lockdowns have resulted in very little coming into the continent, and lockdowns have also resulted in our inability as a continent to be able to purchase what we require. When we do screenings, when we do surveillance, our health workers are shifted, and therefore Ncds is affected. And of course, all other public health assets from the very top all the way to the very bottom have had have had to be negatively affected. And in this way, Ncds has suffered during the pandemic. Now, when we focus on mental health challenges specifically, we saw from the very beginning, well, now it is going down, but we saw from the very beginning the fear with which we received COVID-19. And it is precisely of the nature of ease of spread and very high morbidity and mortality rates compared to other similar viruses. This meant that even rational situations became irrational. When we could have been able to act rationally and looked at the pandemic from a global perspective, many countries decided to close off everything and they consume whatever it is that they produce. And Africa suffered in a very big way. But at the individual level, just being known as having COVID became almost like a death sentence in the beginning. You can't travel, you can't get out. We were literally, when you're pronounced positive, you are literally locked up. And this was not very good for mental health. The stigma that came with that also was not very good for mental health, particularly in the beginning when we did not understand it very well. But that stigma, that fear, that maltreatment stays with somebody for a very long time. And this has meant that mental health of those individuals has been very negatively affected. The fact that we created special centers for testing, special centers for quarantine, special centers for treatment, indeed, special ways of even disposing of those bodies that were as a result of COVID, meant that we treated the disease in a special way, and anyone who was associated with the disease immediately became removed from society. And this affected mental health in a very big way. Lockdowns resulted in isolation. Lockdowns resulted in difficulties economically, socially. Lockdowns disrupted everything that we knew to be normal. And in this way, our mental health was affected in a very big way. You see, when something is not talked about, like mental health, although we could be able to count the number of people who are tested positive, the number of people who are hospitalized and those who passed away, we were very slow to count the number of people who are being affected from a mental health perspective. And we don't have very clear documentation of that. And Muhammad, maybe that is where we need to start with the UN colleagues. We go out and we see just how big is that burden when we look at mental health in the context of COVID-19. But for sure, as we go back towards what is the new normal, it is very clear that what we have seen during this pandemic tells us that mental health is urgent to be taken care of. NCDs are urgent to be taken care of, and that action needs to begin now. And that is why, as Africa CDC and the Africa Union, we are very pleased that all of you could be able to set aside time and come so that we can be able to put this strategy on the road and we begin using it as quickly as possible. During the pandemic, we've learned a lot of lessons. And these lessons, we have documented some, we continue to document others. Our ambition is that those lessons need to be translated into better public health in terms of preparedness and response to health emergencies. Also, they need to be translated into better healthcare because there are issues that we have learned during this pandemic that impact on the way our health systems operate and the way that we invest in healthcare in general. So some of these lessons we are trying to, I'm going to link them to the Ncds, injuries and mental health discussion so that we see how we can be able to adapt and take advantage positively of those lessons. One is, and I say this, and I'm happy to be quoted, that multilateralism at the global level failed Africa during this pandemic. Because in the beginning, getting test kits was a challenge, getting PPEs was a challenge. When vaccines came, getting vaccines was a challenge. Yet, this was a global pandemic requiring global efforts. We need to relook at the way multilateralism addresses a global health emergency. If we don't, then we'll be in the same space we are in today when the next pandemic comes. On the other hand, regionalism is what protected this continent from being overwhelmed by the COVID-19 virus. Our heads of states from the word go, the first case when it was documented in Egypt on February 14th, a week after that, health ministers were here meeting to put together a strategy on how we can be able to address the pandemic. And about 2 weeks after the ministers had met, our heads of state started meeting virtually, but they were meeting very regularly. During 2020 alone, we had meetings of our heads of state at the Africa Union Bureau level, nearly, I think, 18 times in 1 year, unprecedented. So coming together in solidarity, coming together as a continent, strengthened our regional approach. And this tells us that if we take things as neighbors, as a continent, we can be able to act in a way that actually supports the priorities of this continent. So under the banner of just regional capacity building, from the top all the way to the bottom, we've learned things that we can be able to use in the Ncds mental health space. We need to come together. This is imperative. There is absolutely no option. If we don't come together, we will not be able to tackle Ncd's mental health in the way that we are supposed to do it. And we have learned that from COVID, the pandemic. We must be able to coordinate and harmonize our policies so that they are synergistic at the national level with your neighbors, and usually through our regional economic blocks, and also at the continental level through the Africa Union mechanisms. We must ensure that we are coordinating so that we harmonize what is going to be done at country level. We must strengthen and make more efficient the way in which we develop a common African position. During the pandemic, our heads of state will meet regularly and they will take a stand, and then we will be able to implement those decisions that they have made. We need to do that for Ncds and mental health as well. We must invest more in our own research. We must invest more in our own innovation. We must invest more in how we use technology to be able to address the challenges of Ncds and mental health. And we need to ensure that our partnerships are based on our priorities. This is one of the strong pillars of the new public health order that the director was speaking about in the morning. And these partnerships need to be adapted to the African situation. That way, whatever it is that we put down, like what we are going to discuss of this strategy, what we put down, we must ensure that we implement it. And when we implement, we can be able to get rid of diseases that we can control quickly as we deal with those that may be able to take a little bit of time to bring under control. But nevertheless, the partnership starts at home, goes to your neighbor, and then it will spread to the whole continent before eventually it influences what is happening around the globe. Now, apart from that lesson in regional capacity building, we also had lessons in how to cooperate. And because we were cooperating on the continent as African countries, and we were supported by partners who aligned with our priorities, we were able during this pandemic over the last 2 years to put together different initiatives that actually guided the way in which we approached prevention, control of the COVID-19 pandemic. I'll not go through these, but it is a whole discussion around what initiatives did we put on the table and how did those initiatives positively influence the way in which the trajectory of COVID played out here on the continent. How did we keep the numbers low? How, whether it was infected, whether it was those who got the disease, or who were hospitalized, or those who actually passed away. These are an example of how, when we cooperate, we come up with mechanisms that actually help the continent. And we need to learn from this within the Ncds and mental health space to do something that is similar with respect to Ncds. The other lesson we learned is that we must cooperate, we must collaborate, we must coordinate and communicate within the continent. And the only way for us to be able to do that is to appreciate that everybody brings something on the table, irrespective of which sector you come from, irrespective of what level you are at within your sector. Everyone brings something so that public health can be able to be protected. In fact, if any sector fails, whether it is water, whether it is security, whether it is engineering, the result is a public health problem. Whether it is a bad road, whether it is bad food, whether it is unclean water, whether it is a virus that has not been controlled, it becomes a public health problem. So in our approach of addressing the pandemic, we also brought together everybody and utilized frameworks that could be able to be utilized by all different sectors. Secondly is we ensured that the priorities of the Africa Union and the continent, therefore, brought together all the organs, all the agencies, all the institutions of the African Union were working together. All the member states through the different platforms, whether it was at the continental, at the regional level, all of them were working together using initiatives and advice that was coming from a single place, and therefore they were aligned and very synergistic. So let's utilize that experience And we mainstream Ncds and mental health into all the work and all the initiatives and the platforms made available by the African Union, all the platforms made available by our regional economic communities, and all the opportunities at country level, so that we ensure that Ncds is part of the discussion every time that there is a public health and indeed healthcare and developmental discussions at that level. And the models that we have developed during this time are possible to be able to use, as we will see later on in the discussion. Still under cooperation and collaboration, communication, coordination, we set up the Africa Task Force for Novel Coronavirus. And this task force was established before we had a huge problem on the continent. It is made up of directors, national directors of our National Public Health Institutes or national CDCs. It is made up of directors of health emergencies within ministries of health, and also our key partners and ourselves as Africa CDC as a secretariat and a co-chair. Now, this model ensured that we had regular meetings at the technical level, and we will be able to assess what is happening on the continent, and we will be able to utilize that information to come up with possible scenarios on how to prepare for the coming months for the pandemic. And because we escalated that discussion, so the technical colleagues will meet at the level of the task force, and then it will be escalated up to the ministerial level, and then it will be escalated further up to the heads of states level. It meant that there was communication that was relatively quick compared to the usual way of us having policies being generated within the African Union. Usually it takes 2-3 years, but here is conversation that will take a week to be able to have started at the technical level and to reach the heads of state. A decision is made and countries align in as far as implementation is concerned. So let us utilize that experience and lesson that we have had in during this pandemic and establish something similar for Ncds. I know there are many Ncds alliances at country level, at sub-regional level, regional, continental, and even global. But let's look again at those alliances and see how do we ensure that what is being discussed at the technical level is quickly escalated up and decisions are being taken that are good for controlling Ncds and addressing the mental health challenges. And when we are doing that, we bring together everybody who's working in this space, whether they are public or private, whether they are from institutions for research and education, or whether they are from governmental institutions, whether they are from non-state actors. We need to bring everybody together and ensure that we are all speaking with one voice for this continent. Still within the 4 C's, the cooperate, collaborate, coordinate, and communicate lesson that we learned, we also learned that when we establish our own platforms, then we gain better. And I'll give you one example. Out of the 12 that I'd shown, if you look at the African Medical Supplies Platform, and I think Mohammed also already touched on it here, it's a very important initiative that was set up. In the beginning, we could not be able to get particularly test kits and PPEs. So what we did was to put up the platform and then go and engage with manufacturers and make those products available on the platform at a pre-negotiated price. The only thing that will change is the transport cost, depending on where that commodity was coming from and where it was going to. In this way, we also started the journey of encouraging our local manufacturers on the continent to expand their manufacturing, because we have a platform where governments will come and will buy. And many African governments came to the platform, they bought their commodities, and they were able to be delivered in good time, much, much more simply than if they had done it directly using their own procurement mechanism at country level. It is important for us to be able to create or adapt the platforms that we have to Ncds and mental health so that we can be able to get the advantage. I mean, 1.3 billion people is a lot of people. It's a big market. And we need to utilize that strength to negotiate properly and to ensure that our local manufacturers have a market for whatever it is that they are manufacturing. And out of all these 12 different initiatives that we did, what it taught us, the lesson we learned, is that we need to actually create a momentum around an initiative or two for NCDs and mental health that we can be able to use as the flagship for this strategy, as a flagship for your work, so that this continent can be able to give results as quickly as possible. Around resource mobilization, we also learned quite a few lessons. When we were at even today, many partners are coming and wanting to work with Africa CDC, not because we are the best at doing what we do, but because of the honor that has been given to Africa CDC by our heads of state and our policymakers at ministerial level and below. We have been given a mandate and we are carrying forward that mandate. When we have this strategy and we establish the structures that need to be put in place for the strategy to be successful, you will have been given a mandate. And we use that mandate to go out and negotiate. We negotiate at country level with our governments, with the private sector at country level. We negotiate at the continental level with philanthropies and private sector. We negotiate at the global level with different partners so that they know that when they're dealing with this group, they're dealing with a continent. And this is the advantage that Africa CDC has had. And when we go out to mobilize resources, and we are mobilizing resources for the continent, and we are mobilizing on activities that have clearly been prioritized by our policy-making organs, and therefore we have legitimacy when we go out and we do the negotiations. We know how low the investment in Ncds is. We know how low the investment in mental health is, and we need to change that narrative by putting together an infrastructure that has mandate, and that infrastructure that has mandate can then be able to go out and negotiate for more resources and negotiate for better outcomes when decisions are being made. But after you get the resources, these are another lessons we learned, is use the resources in a way that produces results. And when your results are good, then more people will come. And this is the simple lesson that we need to really carry through to the NCDs and mental health space. We utilize the resources well. Another lesson is around workforce. We saw during the pandemic, we could not be able to move. And so meeting like this was not possible. But our teams became innovative and flexible, and using online platforms, we did some really fantastic work. Very big numbers of African professionals were trained. And when the system started opening up a bit after the lockdowns, we then were able to give hands-on refresher courses. We need to do the same for NCDs and mental health. Let us ensure that we identify which are the important areas that need capacity building, and we strengthen ourselves. Of course, we, at the back of our minds, we will be speaking with the policymakers that after we train these colleagues, let us not allow them to be harvested by other organizations and other countries. We need them to stay within Africa. And we have to come up with mechanisms of keeping those that we have trained here on the continent. So just a few examples of what we did and the results of those during this period of the pandemic. In infection prevention and control, for example, we thought we knew what IPC is. But when the time for action comes, the lessons we had learned during the Ebola outbreaks, both in West Africa and particularly in the DRC, gave us some very good, solid head start. And that is why the numbers of our health workers that were getting infected were better than elsewhere in the world, despite the fact that we are the ones who are suffering lack of PPEs. So a lot of our professionals were trained, over 24,000 of them in a very short space of time. Our health emergency operations centers, we also train those online. We train colleagues in surveillance. We train community health workers. We train laboratory personnel. So the opportunity to be able to build our capacity locally is there. The lessons are there. The tools we used are there. And in fact, I think the momentum that we have created is going to make it easier for us to be able to train more and more health workers when it comes to NCDs and mental health. Multi-sectional work is the core of what we need to do within NCDs. just as it was during the pandemic, we must be able to ensure that every sector that is relevant is brought together. And we saw it happen during this pandemic. As Africa CDC, we could convene through the Africa Union, we could convene ministers who are outside of health. Ministers of finance have been meeting regularly. In fact, the most regular meetings have been health ministers, but the second most regular meetings have been with finance ministers, convened by ourselves. Ministers of transport during lockdowns came through and put in place very clear policies. And all the others, whether it was trade, whether it is agriculture, whether it is humanitarian affairs, everybody came and made their contribution. We need to build that strong and sustainable link with different parts of society, different experts, different levels of policymakers, so that we can be able to take Ncds and mental health to the next level. So just one or two more slides in terms of lessons learned and how we can be able to take this forward. When we look at the syndemic and the practical solutions that we are proposing, and I think this is going to be discussed over the next few days, is the core is the new public health order that we've been speaking about. And really, I encourage all of us to understand the new public health order as much as possible, because this is the direction that we want to take as Africa Union, Africa CDC, and public health space. Public health institutions must be strengthened. If you don't have an organized national public health institute, an organized national CDC, then your response to any health emergency will always be slowed down by lack of coordination in the beginning. Eventually you get it right, but it takes time, and it means you are losing lives and you are having many more people getting into hospitals. We must strengthen our national public health institutions, all of them. Whichever angle they are coming into public health, we must strengthen them at the national level, we must strengthen them at the regional level, and we must strengthen them at the continental level. And at the continental level, Africa CDC and the Africa Medicines Agency become the go-to institution that needs strengthening. If we strengthen them, then we become more organized in the way that we respond. Public health workforce. We must train more of every cadre that we need within the health system, and particularly for Ncds in this case. And not just train more, we must train them to the right levels so that we always have capacity building happening within the continent and don't have to go far to be able to get training to happen. When you are doing all that, strengthening your institutions and strengthening your health workforce, you must secure your supply chain. You can't have the soldiers and then they don't have the weapons to be able to fight with. Our supply chain must be secured. We must manufacture what we need here on the continent. We have a very strong push for vaccines manufacturing right now because of the recent experience with COVID. But everything we must manufacture here, whether it is test kits, whether it is PPEs, whether it is therapeutics, whether it is machinery that we need to ensure that we are manufacturing it here. And as we do the manufacturing, we must have our regulatory bodies to also be strong. And those regulatory bodies are the ones who are going to be able to say, this product is good, so put it out into the market. Unfortunately, Africa is the only continent that still has to wait for someone else to declare that that vaccine is fine. Small countries like Cuba, big countries like China and India and everything else in between are doing it on their own, except us. So we must make sure that the Africa Medicines Agency is operationalized as quickly as possible. But when we do all that, partnership is critical. And partnership will be for all types of resources, including money. And the best partnership is the one at country level, where the government and the private sector, indeed members of the public, will come together around an issue and deliver on it so that anybody else coming to help, you are helping what has already started. Not that someone else is coming to help you to start it. You must start it locally, and that is why sustainable financing at the local level becomes extremely, extremely important for us going forward. We've learned this in COVID. We we must do it with Ncds and mental health. In conclusion, this is a busy slide, my apologies. A few things that we must go away with as we go into discussions. This must be done at the continental level. You cannot be able to do it at an association level, at a public health school level, at a ministry level. You can't do it at a government level. This is big enough for us to do at the continental level. Second is we need to ensure that every investment we have made during COVID, in terms of capacity building, in terms of building institutions, in terms of initiatives that are actually working, in terms of partnerships that we have already developed, we must ensure that those investments are paying off for healthcare in general, and in our case, for Ncds and mental health. All we need to do is tweak what we have learned, tweak what we have built, and ensure that it delivers for Ncds and mental health as well. Third is that we need to build on what we already have. And every country already has a lot. Many times we look down on what we have and we look at what is happening elsewhere. And often we wait for the assembly in May in Geneva to go and discuss a particular policy, while at country level, and I think the example for Nigeria is very telling, we have laws that were made in 18 something or 19 something. We need to start there. We don't have to wait for entities from outside to come and do that support at local level. We must build whatever resource we have locally, we must build it and refine it so that it actually addresses all the issues that are covered by the new public health orders of institution, of workforce, of supply chain, and of partnership and sustainable financing being made available for Ncds and mental health. It has been a very painful 2 years, but let's use the lessons to make the next 2 years softer for Ncds and mental health. I thank you.
Thank you so much, the Deputy Director. Really a stimulating presentation. Dr. Ahmed took us around to see what Africa CDC had done in the past 2 years. And it should not be a wasted opportunity. He made you to see what we've done in the area of bulk purchasing, coordination of what we are doing on the continent, workforce development, local production. And he ended by saying that this investment, that huge investment for health system that's been done during the time of COVID, must also gain Ncds and mental health should have dividend from it, meaning we should link them. For instance, he talked about the local production. We should ensure that whatever policy Africa CDC is supporting on the continent, it has an NCD link. If I give an example, Dr. Eno is here. He's been championing diagnosis using cutting-edge technology, pathogen genomics. He had a group called the AFCAD group that can be very useful for diagnosis in terms of mental health. Dr. Ahmed, thank you so much for this very, very stimulating presentation. So we still have maybe 20 minutes for question and answer. So I will invite, yes, the two previous presenters and Rosemary online, so that if the question goes their way, I will just direct it in their direction. So please, if you want to take the floor for question, can you just indicate? Yes, yes, yes. 4, 5. So let's start with this 5. You unmute your mic. Yes, unmute your mic and make your intervention. Thank you. Yes, please go ahead. There is interpretation. Yes, please try to get the channel. For English speakers, it's channel 1. French is 2. Arabic is 3. And Portuguese is 4. So can everybody who does not speak French, I speak French, so I don't need it, but I'll just put this up.
Okay, thank you, moderator. I pick out my head because I must be serious. D'abord, je vais remercier le professeur qui est venu de Nigeria. Moi-même, je suis neuropsychiatre de l'université de Kinshasa. J'ai aussi la chance de travailler au gouvernement. J'ai aussi la chance d'être clinicien. J'ai commencé mes études par la médecine interne, mais vu l'ampleur des problèmes de neuropsychiatrie au Congo, après avoir eu ma spécialisation en médecine interne, je n'ai pas voulu continuer à faire la thèse en médecine interne, puisque le problème était très, très sérieux à notre niveau. Le professeur a souligné un problème très sérieux, la fuite des cerveaux des neurologues et des psychiatres de l'Afrique vers les pays nantis. Le Congo n'a pas 1000 neuropsychiatres et 100 neuropsychiatres. Mais sur les 100 que le Congo a formés, plus de la moitié se trouve à l'étranger. Et même la France a ouvert un système là de DFM et de FMSA pour récupérer les quelques neuropsychiatres de CNPP et les amener là-bas. À tel point que le peu de neuropsychiatres qu'on trouve au Congo ne se retrouvent qu'à Kinshasa, 3 à Lubumbashi, et moi je suis l'unique de Kisangani pour tout l'Est du pays. Alors, je voudrais qu'au cours de ces assises, nous puissions stigmatiser cet aspect-là, professeur. Puisque nous n'allons pas aborder le problème de santé mentale sans qu'on ait une masse critique des neurologues et des psychiatres. C'est pratiquement impossible. Or, si vous faites l'inventaire des neurologues et des psychiatres à travers les pays africains, vous allez voir comme l'Afrique, la République centrafricaine n'a pas de neurologues ni psychiatres. Comment on va aborder ces problèmes au niveau de l'Union africaine? Donc, nous devons vraiment voter des résolutions ici pour voir comment mettre fin à cet exode des cerveaux pour que ce que nous voulons faire puisse réussir. Deuxièmement, il y a la différence entre la gravité et l'ampleur du problème, ainsi que les interventions et les moyens mis en œuvre pour aborder les problèmes. Et je pense que je voudrais que chaque jour pour CDC Afrique, par rapport à la santé mentale, qu'on puisse garder les sujets par rapport à les gaps à combler est immense. Quand vous prenez mon pays, la République démocratique du Congo, les gens vivent depuis plus de 25 ans en guerre. Et ce n'est pas n'importe quel type de guerre. Vous sortez le matin, vous trouvez, on a coupé une personne en plusieurs morceaux. Et vous êtes obligé de vivre dans cet espace pendant 20 ans, 30 ans. Vous devenez qui? Alors, c'est pour montrer que les problèmes de santé mentale nous demandent aujourd'hui beaucoup de moyens. De la même manière qu'on s'est mobilisé pour Ebola, pour sauver déjà à l'Équateur, arrêter les épidémies, à l'Afrique de l'Ouest, qu'on essaie un peu de se mobiliser par rapport à la santé mentale et aux maladies non transmissibles. Quand vous allez dans certaines provinces du Congo, comme dans le Kasaï, la malnutrition a déjà atteint des proportions incommensurables. Qu'est-ce qu'on peut attendre des Africains avec des cerveaux qui n'ont pas mangé? Parce que c'est la nourriture qui construit le cerveau. Or, vous allez voir que la malnutrition est chronique chez nous. Comment on va avoir une élite africaine qui va sortir des enfants qui n'ont pas mangé, des mères qui ne mangent pas et qui mettent au monde des enfants? Qu'est-ce que nous espérons par rapport à cette Afrique-là? Et vraiment, ce forum me permet quand même de communiquer pour qu'on puisse décréter cette urgence. Et le problème, par exemple, la prise en charge, c'est que le professeur en provenance de Nigeria a mentionné. Mais quand vous allez dans d'autres pays africains, au moins chez eux, il y a une organisation. Chez nous, au Congo, il n'y a que l'OMS qui essaie de financer la santé mentale. Et souvent, elle ne finance que la journée mondiale de santé mentale. Après cette journée mondiale de santé mentale, les activités de santé mentale se taisent. Donc, nous devons pousser l'OMS que la santé mentale ne soit pas seulement un sujet de la Journée mondiale de santé mentale, parce que quand vous passez dans toutes les villes africaines, j'ai vu la même scène. Quand je passe par ici, vous voyez qu'il y a des malades mentaux au bord de la route. Quand vous arrivez à Kinshasa, c'est la même chose. Quand vous allez au Rwanda, c'est la même chose. Donc, pour ne pas abuser de ça, on va voir. Je me limite là pour qu'on puisse prendre cet aspect de choses comme une urgence maintenant, comme on a pris Ebola, comme on a pris Covid. Merci.
Excellent. Thank you so much for that presentation. Yeah, you really hit the nail on the head. I believe part of the question is for Professor Sheikh, and maybe Dr. Ahmed may want to respond to some of the Africa CDC issues you raised. But let's take the second, let's take everything in bulk, then we'll come back to the second person. Please unmute your mic. And because we're running out of time, your lunch is ready. Let's keep the intervention very short. Thank you.
Thank you very much. Mine will be short. Is about the trust fund. We would want to know more about that trust fund and how can countries access that trust fund, because most of the issues in our countries is about funding for Ncds. As Professor Kaushik presented, really, they are not taken as priorities. Now, if there is this regional or global fund, we would want to know more about it and how we can access that fund for our programs in the countries. I thank you.
Excellent. We will go to Rosemary, and I don't know if Professor Kaushik want to also comment. Third question? Yes, unmute your mic, please.
My name is Dr. Nasri from Ministry of Health, Kenya. My question is to Professor Sheikh. And were you able to put a mental health fund in your mental health bill? And if you're able to do that, how are you able to do that in terms of ring-fencing funding for mental health? Thank you.
Thank you to the lady from Kenya. The second speaker, can you please tell us who you are, so that for the record, before we go to the fourth question.
Yes, I'm Dr. Gerard Mutonji, and I'm the NCD focal point for Uganda.
Thank you. Fourth question.
Thank you very much, all the presenters. My name is Dr. Hafsa Lukwata. I work with the Ministry of Health and Mental Health in Uganda. My question is a general one, but I think it may go to my colleague, I think Rosemary, the one who is talking about the global efforts. We've learned from the past, especially when we had tobacco control, where there's that framework convention on tobacco control. And somehow it went a long way in improving the way we look at tobacco in the whole world. My worry is with alcohol and all the other substances of abuse that are really a problem to the continent. And unless we have these concerted efforts and an approach similar to what the FCTC on tobacco control did, then we may not go very far. So I'm really calling upon the African CDC, if they had the funds and everything, to borrow from that if possible. But I also want to talk about it also in another way, that we need to deal with this with the industry in special ways as an African society. We've had incidences where the industry would get into either a block or specific countries and lure them to support them against the science that is already available. So I'm calling upon all of us, but the AU to lead us in this, to be able to fight the industries wherever they are. That is the sugar, the alcohol, and the tobacco. We need to fight those harm reduction things that are coming on to undermine the efforts to fight the effects they cause to the people. Thank you very much.
Another excellent question. I think this will go to Rosemary and part of it to Dr. Ahmed. Final question, please.
Thank you very much. My name is Dr. Esther Mwinyangwe. I'm the Deputy Minister of Health and Social Services in Namibia. I don't have really a question, but I just wanted to make some few observations, especially on the issue of mental health. And allow me also, Chair, to thank all the presenters for their excellent, informative, insightful, and comprehensive presentations. It's good to hear and listen, especially when I was listening to Professor Sheikh, that we are not the only one in Namibia when it comes to the issue of mental health. But I want to share very briefly our experience when it comes to mental health services, especially during COVID-19 pandemic. When we detected our first case in March 2020, one of our pillars that we came up with was psychosocial pillar, psychosocial support pillar. And that pillar made people to appreciate mental health because they have been working with families. We know that with lockdowns, a lot of fear and anxiety were created. So the social workers and the psychologists in that pillar, they serve as the link between the health facilities and family members. If someone has been admitted, they were now the one to inform the family how the person is doing. They even facilitated video calling and so on. And that made us to realize the importance of mental health service delivery. I want to mention that I was pleased to listen to Dr. Sheikh, especially on the issue of mental health bill, because right now we are also in the process of working on our mental health bill to replace the outdated Mental Health Act of 1973. And I'm sure that we can learn a lot from their experience because we want to decriminalize the whole issue where people with mental issues are being discriminated against and being labeled and so on. Lastly, Professor Ahmed also mentioned the importance of research on mental health impact on the research of on mental health as it has been affected by COVID-19. And I really want to support that. And also how we can strengthen, especially our Public Health Institute, in order for us to have timely response to pandemics. My question was on the trust fund, and I don't want to repeat what the previous speaker said because that is also what I wanted to know. So with those few remarks, really, I thank you very much for giving me the floor. Thank you.
Your Excellency, I did not know you were sitting there. Honorable Minister, you are welcome, and we really appreciate your presence. Your intervention has been really excellent. When the COVID-19 started, I was in Nigeria for a training, and I got locked down there. One of the things we worked very hard with the Nigerian Center for Disease Control is to set up a psychosocial component to the COVID-19, learning from what happened during the Ebola crisis in West Africa, where WHO actually mandated psychosocial component to be an integral part of any response to emerging or re-emerging infectious disease. So really, that was an excellent component. And Your Excellency, if you look through the document, you see that it's one of the cardinal areas of work for support to member states. And we can learn from what you've said and how you did it in Namibia. And of course, definitely what Professor Sheikh and his team did in Nigeria can also serve as a way for us to support other member states to learn from that experience if they want to. Having a legislation is the first way to institutionalizing what you're doing. Thank you, Your Excellency, for such an excellent submission. So let's start in the same order we did the presentation. Professor Kaushik, can you come, or you can just unmute your mic so that we don't ask you to, and respond to some of the questions that came your way. Over to you.
Yeah, thank you very much. I think most of the questions are emphasized on mental health and the trust fund. And unfortunately, I'm not very sure about the trust fund. I just heard it today, but I know that there have been a lot of moves towards the innovative financing and trying to find out what financing could be available to support the NCD work within the country. So I think I'm also basically learning about trust fund today, which has been established and which was presented by the lady here. So I think from my side, basically most of the issues here are related to the mental health. And I don't think I have any intervention here.
Thank you so much. So we go to the next speaker, Professor Sheikh. Over to you.
Yes, thank you very much. I must thank all the respondents for their comments. They are quite germane. And I believe when we want to do anything, the first step is conversation, set up of conversation. And just like he said from the Congo, sorry, I missed the initial part of your comments, so I missed the name. I was trying to get interpreter, you know. But it's quite congruent what you said about brain drain. Brain drain is a very complex issue. I remembered during a presentation by Professor Gureje, where he looked at brain drain and he said, is it that you want to blame the thief for coming to steal in your house, or you leaving your valuables open for anybody to pick? So who do you want to pick? You train people, you invest so much in them, you know their area of work is very scarce, and yet you watch them leave without doing anything. And people just come and take them off without compensation, nothing. So who do you want to blame? Is it the owner of the house or the thief? It's so huge. Now, we also want to ask ourselves, our young men are dying across the Mediterranean Sea every day. They are dying across Libya. What is it that is pushing them to want to move away? These are even unskilled young men, young women. So that's why I said issue of brain drain is really complex, something that we really need to look into. And I believe that with this forum, there will be a lot of conversation about it, and we'll be able to come out with certain communique that will advise governments of Africa, because it's a problem of Africa and it's massive, and we really need to look into it. Yes, I agree. There are some countries in Africa today that don't have psychiatrists or even psychologists. We have a lot. We have more countries that don't have psychiatrists than those who have psychiatrists, even in West Africa. I have been an officer in the West African College of Physicians for 12 years, and I've gone around virtually all the West African countries. So I know we have more countries that don't have psychiatrists than the ones that do have one or two. So it's a problem. However, we should learn to share. We should be able to allow where you have quite a number to come and train people for you, to come and practice for you. We must, there is no two way about it. The only way forward today is task shifting and task sharing. We share mental health work with other doctors who are not psychiatrists, and we shift mental health work to people who are not even doctors. And we have the MH Gap Intervention Guide that is very robust. We should contextualize it to our individual countries like we did in Nigeria. We contextualize MH Gap to Nigerian tradition and culture, because the way it is, you cannot just use it anywhere the way it is. So you have to contextualize it to your own specifics. And we can shift the task to people who are non-doctors that will be able to take care of a mild to moderate degree of mental health disorders. But like you said, there is need for massive advocacy. There is need for massive awareness campaign. There is need for us to think differently from the way we used to think about mental health. There is need for us to deal with misconceptions, negative misconceptions, and myths that are surrounding mental health, that are creating stigma. Not only the mentally ill is stigmatized, even we, the professionals, are stigmatized. As a psychiatrist, when I go out to the pub with my friends, The conversation was just changed the moment I entered the place. And that is part of it. So we have to find a way of really dealing with this. And so there is need for massive advocacy, massive awareness campaign. And we have to take this to the doorsteps, to the schools, to workplace, to reproductive centers, everywhere we can. I agree with you. I support you adequately that there is need for resources to be mobilized for campaigns like this. It's very important. And then, yes, there is hunger everywhere. Like I gave you an example of what we mean by policy. I promised my son I'm going to buy him shoe for Christmas. And then Christmas came, his sister falls ill. Then I have to change my priority and use the money for his shoes to take the sister to the hospital. However, if I have opportunity to draw fund elsewhere to take care of the sister's illness and still be able to meet this. So we have priorities, but at the same time, we must be able to have backups. We must be able to know how to deal with our problems. And we can't do that if there is no planning. And you cannot plan without research. You cannot plan without evidence. And you cannot do that without having governance structure on the ground, policies and legislation. So this is the way forward. We need to know how to plan, and we need to have instruments for planning on the ground. And we will need Africa CDC to be able to support the development of those instruments that we need for planning. That is the only way we can fulfill our promises to the people. We can still take care of hunger and still take care of mental health. Then the issue of, yes, Dr. Nasri, your question is really huge. We debated this, and we had people from Federal Ministry of Health in our midst when we were developing the draft mental health bill. In Nigeria, we have what we call the National Health Fund. And within the bill, we have put in there that certain percentage of the National Health Fund should go for mental health. And it is the amount that became a problem between us and the Federal Ministry of Health. The Director of Public Health is here, she's in front of me. So we are still arguing on it, and we are hoping that the President will sign something that is good, that will come, and that will come from the source. And that will ensure a sustainable funding for mental health in Nigeria. So that's what we did for our mental health bill. I think I've been able to address. Thank you very much, Honorable Minister, for your kind comments. I'm really ready to work with you. And once you want my attention, I'll be available. Thank you. Thank you. I hope I've addressed all.
Yes, adequately. Thank you, Prof. So we go to Rosemary online. Rosemary, can you unmute? And
yes, I am here. First of all, thank you so much for the questions. And just a minor correction, nobody calls me Rosemary. Everybody calls me Mamka, Dr. Anyona, but I have never used Rosemary. You know, we all have this first name that we never use. But it is wonderful to see that there are a lot of questions about the trust fund. So I'll address that after addressing the question from the Ministry of Health in Uganda about industry interference. So I do not want to go too much into this question because there's so many other better qualified speakers to talk about this here, but to absolutely agree with you that we do need stronger support globally and regionally around regulation of industry interference. And I too look to the Africa CDC as a potential asset in this way. Africa CDC has this unique opportunity to leverage cross-country support to counter industry interference. Often it's very, very difficult for individual countries to go up against corporations by themselves. There are a number of countries across the region, Kenya being one of them, that have been sued by tobacco companies. And often it is not that easy to go against them with our limited pocketbooks. But there's something that needs to be explored about the power of trying to approach this from a regional perspective and trying to leverage, to this power of the of collective action or the power of acting collectively in response to industry interference. And I do echo that, it is important for us to think as a community about how to approach the question of alcohol control and whether it's important to establish bodies similar to the FCTC as was suggested. But I will leave that to those who are better versed in alcohol control and who have worked in this area for the longest. Although on that, I have to say there's a joint program called SAFER. That's a collaboration between UN agencies and NGOs, including Movendi, who are leading NGO on alcohol control. And they are implementing through the UN Interagency Task Force programming even in countries including Uganda. So there is a lot that is happening in this area, and I invite you to work with the Interagency Task Force on this, but very much as well invite Africa CDC to consider how they can use this platform for countering industry interference. So on the question of the trust fund, it is good to hear that it has piqued the interest of many of the participants today. So the trust fund was only recently established, so there's a good reason that you may not know of it yet. That being said, when the trust fund was established, the WHO sent out through its internal systems a circular letter to member states across the world to let them know of the trust fund. And we did receive a significant expression of interest, especially from the African continent, including from Uganda, who expressed interest in working with the trust fund on mental health specifically. No, actually on Ncd strategy, sorry. And so in this early phase, so we're very much in the early phase of the trust fund. And in this phase, what we are doing is putting all our efforts behind resource mobilization to ensure that the trust fund is fully capitalized so that we can then, and the plan is that once we are fully capitalized, we will, and not necessarily fully capitalized, we do have thresholds. Once we reach a certain threshold, we are going to put out open calls for proposals to countries, and countries will be able to submit proposals and then receive funding through these proposals. So we are hoping that we can put out open calls that are very broad if we are able to get the earmarked funding we hope for. But we also expect that a lot of funders will have thematic interests, and if we're funded in one thematic area, then we'll put out a call for proposals in that thematic area, and we want to ensure that countries are aware of this. So it's good that we are also taking advantage of opportunities such as this one, where there are a lot of Ministry of Health officials and other interested parties in participation to continue to socialize the fund so that you can make sure that you're keeping your ear out for this call for proposals. But that is we expect that to be coming in the next phase. In this phase, however, we are inviting all of you, in spite of your country of origin or the country you work in, we invite you to work with us on advocacy, on elevating the profile of the fund at the global scale and at the global level, and to work with us to support resource mobilization. We are taking an approach where we are working. We are thinking about resource mobilization in a very broad way. While we, of course, will go to a lot of the traditional funders to support resource mobilization, we know that in the past that there have been constraints in this way with regard to Ncds and mental health, and so we are approaching countries from the global south. And as I said earlier, the first 3 countries that came on board are Kenya, Thailand, and Uruguay, and these countries are committed to advocating for the trust fund, raising resources for the trust fund through brokering partnerships with their collaborating countries. And in this regard, I would like to commend Kenya, which is the country in the region that joined the trust fund very early on as a strategic partner, and who are very committed in championing the fund and our resource mobilization efforts. We are also, I would would have liked to have a few more discussions with you, with many of you, if I had been able to make it in person, and that was definitely the plan. Unfortunately, we're not able to do that today, but perhaps there'll be a time to do that in the future. But for Africa CDC specifically, since your NCDI strategy is also nascent, we think there's an unmissable opportunity for us to work together to mobilize funding jointly, or to mobilize funding for the trust fund as well. And we suggest considering, events, for example, an online roundtable discussion where we can explore this question together. And I hope we can continue to carry on this conversation offline. But there's plenty of opportunity within this particular room for supporting the trust fund, and then the trust fund in turn supporting the efforts of the countries represented by the Africa CDC. I hope that answers all the questions.
Thank you so much, Dr. Mamka. I hope I got it right now. I settled for Rosemary because it was the safest one to call, and not to incur your words, but it's okay. Dr. Mamka, thank you. Excellent response. And let me say, as the Deputy Director have said, we will definitely link up and find time to sit down and discuss very in detail what we need to be doing together with your team. I can see some hands online. Please just hold on. I'll get back to you as soon as we give the Deputy Director the chance to respond to some of the issues that were raised during the last question. Thank you. Dr. Ahmed, over to you, sir.
Thanks, Mohammed, and thanks to the questions. Some very difficult. Let me start with the one from DRC around the difficulties of resources to do actual work on the ground. This is part of the reason that as Africa CDC, we felt it is extremely urgent that we get into the space, because our model of working is a little different. We are an action agency where we come in, we support real work on the ground. And a lot of the convenings that we do are always linked to some concrete outcome. So to DRC and all the other countries, as we start implementing this strategy, you can rest assured that the kind of support we'll be bringing to the table is one that is based on action and results, so that we can start seeing the implementation changing the face of health, public health in general at country level. Second is, in general, around linking funding in legislation. It's a very tempting idea to put a funding stream in legislation. I'm not saying it is bad, but I'm saying be careful that you don't lock yourself with a funding stream, and the case of Nigeria is good. You end up being told it is 0.5%. And tomorrow, if you go to the executive to ask for any more funds, you'll be told you already have funding in your legislation. Then you end up with a very small amount of envelope to try and make your programs work. So when you're putting in language around funding in your legislations, give yourselves as much flexibility as possible so that you can be able to go back and ask for more if need arises. As soon as you lock yourself into percentages, then the federal government will hesitate to give you more. They'll tell you your percentage is already secured. And those percentages, rarely do they meet the threshold of need. So language around financing in legislation is good, but don't lock yourself in and then miss out on other sources of funding from within the government envelope. Next is the issue of the WHO FCTC experience. It's a very good one. I must admit that I was one of those who negotiated that particular treaty. And its implementation, for sure, I agree with Uganda, that has made a lot of difference. One thing I will commit is the biggest barrier to implementing NCDs are the industries. That's the biggest barrier. And the biggest opportunity this continent has been missing is a voice from the African Union. Engagement with the Union has been relatively weak by member states in as far as tackling the industry is concerned. And now that we are in this space, I commit to you that we will be ensuring that every level and every platform of the union and every energy we can be able to put into the union system will be used to address both at the continental level and particularly at the regional level, using the regional economic communities to ensure that we don't get the industry being the one that is running policy. It must be public health. And we have enough issues to address that under Agenda 2063. So we commit as the Africa CDC and the Africa Union that we will walk into this space as soon as this strategy has been cleared. Finally is the issue, and thank you, Honorable Minister Namibia, for bringing up these two very important issues around research, evidence, and then strengthening our national public health institutes. Let me start with the research. And a very big kudos to Kaushik for generating us a lot of data. But the consistent thing around the data that Kaushik was sharing is that it's several years back. And it is precisely because we are not doing enough research on the continent. And when we do, we don't do it in a way that we can defend it when we report. So in the area of research, and Mohammed, on behalf of you and the other colleagues, I am committing that we are going to support research and evidence generation at country level, because that is what is going to make NCDs stand out from the others. And I think one of the very first places we could try, Mohammed, is working with the health economics program within Africa CDC. We generate some early data on economic effects of some of these products: alcohol, tobacco, sugary drinks, salt, non-exercise, etc. We can be able to do that because there's enough material. All it needs is someone to sit down and do some good analysis and generate some good data. Research we are going to support, and it is one of the priorities for engaging policymakers. Strengthening our national public health institutes is such a core mandate, Honorable Minister, that I will ask that Mohammed, if Taj can be able to speak with the Minister during the course of this meeting. That way we see where Namibia is and we can be able to support the establishment of the National Public Health Institute. It is a core responsibility of Africa CDC, and any country that requires some support will be very happy and open to be able to do that with you. And I think those are the issues that came up. Thank you for this round.
Thank you so much, Dr. Ahmed, for the excellent response to the Africa CDC side. And I'm so sorry. Well, we'll have to take a second round. I know lunch is waiting, but let's start with online. Natalie, can you unmute? Okay, hold on, Natalie. Natalie online, then second, third, fourth, fifth. Let's hold. There's always time for discussion, because when we come back from lunch, I don't want your food to get too cold. So let's take these 5. When we come back from lunch, then we'll start first with more questions than before we go into the next session. So Dr. Natalie, over to you.
Good afternoon, esteemed colleagues, and thank you so much for providing this opportunity for engagement. It's incredible the work that has been done and the work that still needs to be done. I just want to pick up on the aspect of research and evidence. And I think there's an opportunity for us to get involved in workplaces. Many times the public sector is the largest employer in the member states. But I think we also need to make inroads into the private sector workplaces to do the surveillance and gather evidence on non-communicable disease, mental health, its effects on absenteeism, and certainly collate this evidence across member states to make a stronger business case of why it's important for further investment in non-communicable disease and mental health interventions. But also, when the public sector or private sector engages with their individual employees, that they consider extension into families as an intervention for gathering the surveillance and tracking what specific interventions have the most effect. Thank you, Chair. Over.
Thank you very much. Well, I'd like to start off. Well, my name is Dayo Adetifan. I'm the Director General of the Nigerian Center for Disease Control. I'd like to commend, of course, the speakers for all of the excellent interventions. And I thought I would make a few comments or ask a few questions. So the first thing that continues, we've talked about research now, we've talked about need for evidence and data. And the thing that still strikes me or is a source of confusion for me really is what exactly is it that governments or policymakers want or need to be convinced that this is the right place to invest? Because I mean, a lot of us here work for government, and where I recently now also work for government, and I'm not sure I really understand myself what you need to actually put down to the people who actually control the purse strings to make sure that they commit the funding that is required to, whether it's for Ncd or for communicable diseases or the like. The point is, other things in even with the poorest countries, other things in the country get funding, including things that we all may agree are somewhat more frivolous. So what do we need? And perhaps maybe that's for whatever equivalent of a Nobel Prize. What do we need to present to those that are concerned to make sure that they put the investments where they are required? I mean, there's a lot of questions. So related to data, obviously, is research. We've talked about problems with research and data, whether it's Ncd or whether it's even for communicable diseases compared to our peers from other settings. And I think it's important that we address this as a challenge to the ecosystem. Again, we are talking about health, but actually the problem is with, again, our educational sector, our academic institutions, our research institutes. Some of it is a problem with training. Some of it, again, is a problem of no investments. We cannot keep coming. It's the same narrative. We come to the African CDC, we literally have our cap in hand and say, African CDC, come and help us bring funding. You go to WHO, we say exactly the same thing. Again, at what point or what do we need to convince those who control the resources that it's important to make these investments in your country, because your policy will be better informed and hopefully you have a greater impact on public health. And what do we need to do as African CDC or as all of the colleagues here to ensure that our healthcare, our policymakers make the appropriate connection between health and the economy? Because I think that is a very, very, very wide gulf. People don't seem to think about health in context of economy. I mean, the pandemic shows us that this is what happens when you have a threat to health and livelihoods. But Ncds, the rising burden of Ncds, predominantly affecting the people in the working age group, is potentially a risk for respective economies, and this needs to be addressed. Finally, I just thought I would also touch on, again, related to consuming data
related to economy is this idea that we continue to outsource the decisions about our priorities, the decisions about our needs, either as a country, as a region, as a continent, to external parties is also something that I think we need to address. So yes, there might be missing capacity in some areas, but the good thing is that no country exists in a vacuum. You can borrow from what already exists. But why is it that countries do not listen to their own experts, but wait till once African CDC says it or WHO says it, and suddenly it is important? Thank you very much.
Thank you, Dr. Adetifa. I think the panelists should prepare to answer this question, and I'm looking in the direction of Dr. Ahmed. Dr. Natalie, please, for the sake of record, can you tell us who you are?
My apologies, Chair. I am Natalie Myatt, Dr. Natalie Myatt. I am the Deputy Director of the National Institute of Communicable Disease in South Africa.
Thank you. I know that, but some people in the audience may not know. So thank you, Dr. Natalie. The third question, please unmute and ask your question. Who is the third? Can you raise your hand if you're having technical difficulty? Yeah. No, we selected some. Unmute your mic if you're among those we selected and ask your question. Yes, please go ahead.
All right. My name is Patrick Zibocha. I'm from Botswana. I'm coordinating mental health. So my question would be actually directed to Professor Shek. But some of them are just comments that let me probably say, I really thank the presenters for their enlightenment into this area of NCDs and mental health. I think we touched a lot in terms of governance. And I'm also glad that my country, Botswana, has now not reviewed Mental Disorders Act, but rather repealed it because it was quite archaic and it had a lot of derogatory terms into it. But what I want CDC to focus on is that, in Africa, there is, in some of the country anyway, there is a historical imbalance between institutional care and community-based care. And therefore, I think what CDC has to do is to focus probably onto community-based care of mental health, which is lacking. Because we are seeing a revolving door syndrome when those who are institutionalized are discharged, they really go back to these institutions. To me, I would want to see these institutions as a backup method rather than actually hosting such clients for a long time. We did talk about deliberations matter about on human resource, issues of finance, issues of logistics, issues of research. But yes, of course, there was a bit which was left in terms of issues of mental health data. That mental health disorders remain widely underreported, I think even in Africa. A wise man once said, if you cannot measure it, you cannot manage it. So we need to actually dwell on this area. Dr. Shak, you actually mentioned a bit of suicide issues in Nigeria. And literature has shown that suicide is not a crime in Nigeria, but attempts, yes, of course. I would want you to elaborate a bit on that. And the last comment is that, when COVID started, more especially around 2019 in our country, March, that's when now we're up in arms. I really realized that we are running two pandemics here, but it was quite ignored because mental health is an ignored aspect of health. The COVID virus was taken as a pandemic, but issues pertaining to mental health challenges were not taken seriously. And to me, it was a pandemic. Thank you very much. Those are just my comments.
Thank you very much. Professor Sheikh will answer in a while. Yes, the female, yes, please. Okay, let's take from the back, then you will be the last. Okay.
Thank you. I'm Dr. Anthony Tucker from Liberia Non-Communicable Disease Program. I want to thank the presenters. I think they have brought out the issues, and especially the first presentation on non-communicable diseases and the challenges, taking into consideration human resource, access to health, essential medicines. You know, most of these challenges are related or can be minimized by the system. But I think also there's a particular challenge that there's a need for us to also look at, and that has to do with challenges that relate to the patients themselves or the society. I'm saying this because we have realized that a lot of times patients come, especially in our setting, they get admitted into care, they are responding well. And for non-communicable diseases, most of the time, some of these patients will want to cure, and they get influenced by relatives and others, and they get taken to other forms of alternative medicine, especially the traditional healers. These people will remain there, and after some time, they will come back and they are in crisis. And there is one issue that has been leading to increased mortality when it comes to Ncds. And so I'm actually looking at what regulatory mechanism can we put in place to regulate this sector of alternative stroke complementary medicine that's actually affecting us. We saw a situation like that during Ebola in our country, and stringent measures had to be taken. But for this, when it comes to health as a right, I think we still have a challenge. There is not like an epidemic or pandemic situation where we have several persons dying like in Ebola. So what regulatory mechanism I think we can put in place is something that can be highlighted. And I just want to ask the Professor Sheikh from Nigeria, talking about the mental health bill, whether you have any legislation in there that govern the practice of traditional care for the mentally ill. Thank you.
Yes, and thank you, the gentleman from Liberia. Your submission is really very valid. I remember some times ago, people say you put any sugary content in a magnetic cup and drink, even if you are diabetic, it's okay. So risk communication and community engagement is really key in this. I totally agree. I will let the experts respond in a minute. Please, 1 minute for the question. We are really over time.
Merci beaucoup. En tout cas, merci à tous les panélistes et pour les informations qui nous ont été données. Ma question, c'est une question plutôt générale sur la santé mentale. Tout à l'heure, mes prédécesseurs ont parlé de la santé mentale en tant que cadre législatif et quelles ont été les places de cette médecine non conventionnelle, cette médecine parallèle. Parce que, comme vous le savez, 80% de ceux qui recherchent des soins vont, surtout dans le contexte africain, dans les médecines non conventionnelles. Et là, est-ce qu'ils ont été impliqués dans la rédaction de cette cadre législatif, ce projet de loi? Parce que vous savez, les gens, lorsqu'on parle de santé mentale, les guérisseurs traditionnels, les religieux ont des places importantes. Donc, est-ce qu'il y a des expériences là-dessus? Deuxième point, c'est par rapport à la recherche. On a souvent tendance à penser à cette notion sanitaire médicale, mais on n'a pas assez de recherches, de données factuelles sur les recherches socio-anthropologiques. On a parlé d'insuffisance de neurologues, de psychologues et de psychiatres, mais il y a aussi un manque de ressources en termes d'anthropologie médicale, des sociologues, est-ce qu'il y a dans cet aspect-là des appuis qu'on peut faire sur la formation de cette branche de spécialité en médecine? Merci.
Thank you so much. We will now take answers from the experts. Maybe we try to keep it very short because, well, I'm fasting, but I that's my conflict of interest. I don't want other people to fast because I'm fasting. So we'll take maybe a very abridged answers from our panelists, and then we will have some announcement and go for lunch. Who wants Professor Kaushik?
Yeah, I think I'll take the question regarding what does we have enough evidence and what does the ministries or the respective governments require to provide additional resources for the Ncds. I think the gaps which we have is that at the national level, I think the multi-sectoral involvement is not there. And as we know that around 60 to 70% of the risk factor which we have for the Ncds are outside the health sector. And somehow we have not got our act together at a multi-sectoral level, at a country level. That's number one. Number two, most of our income from the Ministry of Finance, if you see, is generated from tobacco, from alcohol, from soft drinks, and from the food. So if you want to basically tell them to cut that off or to cut off those components of income generation which they have within the taxation, there has to be an alternative plan. And as Dr. Ogwell mentioned, I think what you need to do is to generate a lot of economic data for the politicians to understand that if you are going to save money here, what is going to be basically the net effect, what you are going to have at the outcome. So for example, if we are able to manage a person with hypertension adequately with an optimum treatment for about 5 to 10 years, then you are going to reduce how many patients going into chronic renal failure and going for dialysis. And at the end of the day, the dialysis is being paid by the public sector, which is much more expensive than giving the primary drugs. So I think it's a question of making an economic sense of what we want to do and what interventions we want to do. And I think that data needs to be generated adequately. Thank you, Mr. Chairman.
Thank you, Professor Kaushik. Excellent response. Professor Sheikh?
Yes, thank you very much. I want to start with a part of what the Director, Nigeria CDC, part of what he commented on, the issue of outsourcing. Yes, it's true. When foreigners come, our policymakers easily embrace them, mostly because they come with some funding. From my own personal experience, twice I've been able to win grants to do some work. And whenever I win such a grant, all doors are opened. The policymakers open the doors for me. So that's a major thing. When you come with some funding to execute what you want to do, they will open the door for you. But I'll allow Dr. Ahmed to talk about others. And Dr. Ahmed, the National Health Fund for Nigeria is a consolidated fund. It's outside budget. It's what you take off from taxes and you keep in a consolidated account. So it doesn't affect the budgeting, the normal budgeting for your programs. Okay, my brother from Botswana, sorry, I didn't get the name very well. Please accept my apology for being so informal. The institutional care, we are all moving away from it. From my presentation, you could hear that. The way forward is tax shifting, integration of mental health at all levels of care, avoiding standalone mental health institutions. We all know what that means. I gave you an example of how it even stigmatizes people, how people find it difficult to enter mental health hospitals. They have to check here and there and see that nobody is looking at them. So the way forward is integration. Integration, not only primary care, but even at secondary care level and other tertiary hospitals that offer integrated health care delivery service. Because if you maintain the mental health institutions, if a patient has a problem that is not related to mental health, is deprived. So if he has a fracture and is in a psychiatric hospital and there is no x-ray, no orthopedic surgeon, he's deprived. So we encourage tertiary institutions that have integrated services to also cater for mental health. So also secondary services and primary healthcare level. We must also understand that there's a difference between community-based mental health care and primary health care. Community-based healthcare system can be very expensive and could actually require a lot of resources in terms of human and capital resources. But then that is the best if we can get there, and we are marching towards there. We believe if we are able to get into primary care, we'll also get to community-based care. There are two different things, actually. Then the issue of suicide and attempted suicide. Yes, as I'm talking to you now, there is a bill before the House of Representatives in Nigeria that is going for public reading. The bill is about decriminalization of attempted suicide in Nigeria. So it's something that has to do with the criminal justice system. It is not just about policy or things. It is embedded within the criminal justice system. We have criminal code and penal code in Nigeria, and it has to be repealed. So there's a bill in the House of Reps that is being considered, and hopefully we'll be able to decriminalize attempted suicide in Nigeria. As it is now, even if you call a police for a case of attempted suicide, practically nothing happens because we have carried our advocacy, our awareness, our campaign to the police. We have involved police, involved judiciary, so they actually don't go out to punish people anymore, even though the law is still there. But we are working towards repealing of that law. And Dr. Anthony from Liberia, yes, traditional care setting. Yes, we must. You can only control what is within your ambit. When we say about 70% of patients go to traditional care before they come to us, that is beyond our control. And once it's beyond your control, you must recognize the existence. You can't pretend that there is no traditional care. So it's there, we recognize them. The National Mental Health Action Committee, which is the highest policy-making body for mental health in Nigeria, seated within the office of the Minister of State for Health. During our meetings, we do invite traditional carers. Some will come, some will not come. However, for the sake of I will now roll into the other question related to it. For the sake of the mental health bill, the mental health bill takes care of orthodox treatments and permissions for orthodox treatment. But it also takes care of the human rights of the patients. The mental health care the mental health bill will not permit shackling, tying, beating, and abuse of patients who have mental illness. So, and we educate traditional healers about this. In the traditional system, you can give your treatment in your traditional way, but you cannot abuse the patient the way they used to. And that is a very serious matter. And then there is a council for traditional healers in Nigeria under the Federal Ministry of Health. And that council strives to regulate traditional treatment in Nigeria. So that the way we regulate orthodox treatment, we are also regulating, they have their own board. So I cannot regulate traditional treatment. It is the traditional healers themselves that form the board, that develop the ethics for traditional treatment. And they are the ones that will regulate their own care. So that is the way it goes. Before now, we used to have a lot of problems because Orthodox specialists will want to condemn what they are doing. But we're Africans. Not only that we're African, even the Western world, they still use unorthodox treatments. So we must accommodate them. We must recognize that they are there and appreciate what they are doing. I mean, before the coming of the Western medicine, people are surviving. And it's a fact. So we improve upon what they are doing and they regulate themselves. They continue to do what they are doing. So I think I've been able to deal with this. Now, the issue of training, you know, training in traditional medicine, just like I said, they have their board, they have their ethics. So it is their own board that will be able to discuss whatever they have set as guidelines for training in traditional medicine. I am not capable of talking about that. So generally, I think I've answered the questions. Thank you.
Thank you, Professor Sheikh. Dr. Mamka, do you have an intervention?
No, there's no intervention from me at this time. Thank you.
Okay, thank you. Thank you so much. And let's finally get back to the Deputy Director of Africa CDC to round this off. Thank you.
Thanks, Mohammed, and thanks to the colleagues who've asked questions. I think from South Africa, a very good proposal to look at this from a family community approach when we are doing our research. I think that should be able to be discussed during the details of implementation. Now, Director General and Nigeria's CDC, it's very complex answering that question once because policymakers, particularly those who happen to be politicians as well, are different from country to country. But three things I would like to share with you. One is our policymakers at the top level change very regularly. And sometimes you start with one set of policymakers and you do all the convincing that you have. Just before a decision is made, something changes, there's a new set. So the process of quote unquote convincing policymakers is very continuous because they change regularly. Second is we are not the only ones speaking with them. In fact, those who are speaking against the good policies are more than those who are speaking for the good policies, very unfortunately. So it means that when we are speaking to our policymakers, we must speak 2-3 times as often if we are to dilute what the other side is telling them. And unfortunately or fortunately, we do not have direct control over what the policymaker will take as what has made sense to them. And I really urge my technical colleagues, let's simplify our messages so that it is easier to consume by anybody, even if that policymaker is going to tell another one or going to be in a caucus of other policymakers. And three is the level of evidence that we have sometimes is not helpful because it comes from elsewhere. So we'll give data from another part of the world, we'll give data from another country, and I agree fully with you that the research needs to be local because then it gives a very powerful message that this was done here locally and this is what it shows. So as a wise fellow told me that when you're doing your technical work, you need the politicians. When you're implementing, you need the politicians. When it is time to make a case for your area of work, you need the politicians. And that doesn't change. So we need to engage with them on a very regular basis. Remember, we are advisors, we are not the decision makers, because then eventually they make the decision, but we have to speak and speak and speak on a very regular basis. For the local, in fact, let me call it domestic resources for research, it is an imperative if we are to be able to move from where we are to the next level. Because any support that comes from elsewhere has its own I don't want to call it agenda, but let me call it priority. It has its own priority. And our priorities may not be the same as whoever is providing the support. That is why in the new public health order, under partnerships, there are two very important aspects to that. One is the priority must be Africa's. And second, the partnership must be action-oriented. In other words, it delivers something that is directly related to our priorities. When our institutions are strong, then there will be less and less of the challenge that we are facing, where there is some sort of outsourcing to external entities, because if your local institution is strong, then it is more easily heard than if it were not strong. So we really need to build our local capacities, generate domestic resources, and then we do our own research and engage with our policymakers as regularly as it takes for the reasons that I've tried to share there. And then finally is to also commit to the delegation of Madagascar that when we will be doing our mapping for gaps in research, gaps in capacity for health workforce, I assure you that the delegation of Madagascar or otherwise is going to be part of it. We will be doing in fact, we are going to look at this very holistically for gaps, because in research, there are lawyers that contribute to the gaps, the public health space. There will be engineers that make the same contribution. I assure you that scientists, anthropologists, biomedicals, otherwise make contributions. So all of those, in fact, we are going to take into consideration that way when we make a plan for capacity building, it actually accommodates every capacity is going to make a contribution towards contribution. Thank you. I assure you that scientists, anthropologists, biomedicals, otherwise make contributions. So all of those.
Thank you, Deputy Director. I think Honorable Minister wants to make an intervention, and the Honorable Minister, anytime you want to make intervention, just let us know. We'll give you the floor.
Thank you very much. I think it's going to be a fast one. I first start by thanking the Director, the Deputy Director, Prof. and Dr. two presenters, Ahmed, yourself, and all the participants here. Really, the debate has been very interesting, and I was listening keenly. But I came in at a juncture when our brother from Nigeria, the CDC, mentioned the relationship between how you get more funds. All the participants here. Certainly, funds are not enough. So that's how the policy makers talk. They say agriculture is there, education is there, all the others are there. Even within the health sector, all the other areas are there. Apart from the non-communicable diseases, mental health, but EPI is there, other areas are there. Agriculture is there, education. My contribution, even within the health sector, areas are there. Apart from how I'm going to put it, I'll give you a little background of myself, because I was on the other side and now I sit on the other side. As a hospital consultant, spending most of my time in the theater, then moving on to become head of department. So the challenges you are saying at the head of the hospital, it was like the policy makers didn't know really what was happening at the forefront, where the action was taken. Now, as Minister of Health, I actually also understand that sometimes information was not getting to them. It was not getting to them in the form that they could have comprehended. It was not getting to them in an impactful way. Just like Dr. said here, Dr. Catastrophic, the statistics is very important. When we get the data, we simplify it and we make it to them look impactful, because they must be convinced that this is going to make a difference to the lives of the people. Invite them, talk to them, have presentations, and they say, oh, I didn't know this was happening. I didn't know that was happening. Another aspect is the costing, because a lot of times we say we want to do A, B, and C, but it's not costing. When that is presented in the front of the policy makers, they cannot make sense out of it. They just take a proposal and then it's gathered cost on the desk. So typically, and as Dr. Ahmed said, but it's not costing. They are the policy makers and they decide on the budget and so on. But the scientists are not very good at engaging. Scientists are satisfied working on the science. But unfortunately, the science alone cannot succeed. So let's have a forum whereby we engage them, we present to them, and we show them what we are doing. But I think you also say they are politicians, most of them. And that is the truth. If you make it look like what you are doing is going to have a positive impact on their people, politicians and their people, just link it to what will benefit their people, and you see them jumping on board. So I liked that, and I'm still doing that. A few months ago, I told our president a positive impact on their people. Pregnant women struggle to get it on their people, and that probably is the result of quite a lot of this maternal mortality we are seeing. Presented the statistics. I said we need community ambulances. I told our president, now we got, within a few months, we got 80 of them brand new on board because it was linked to alleviating the suffering of his people. So these are the strategies. So we have to be strategic. We have to be able to present and negotiate with them. But I think your line ministry also, they need to be on board. All the way to the level of the minister, because he's the one who goes to cabinet. And when he takes this to cabinet, he is also able to convince the finance minister and negotiate with them, put a case forward. But at the end of the day, people want to see something tangible. In the health sector in Gambia, that's what we decided to do. We put forward tangible things and we let them know what we are doing. We show them. We did A, B, and C. And of course, we've renewed accountability and efficiency. Even the finance ministry is on board, and other partners are also coming, because apparently the partners pretend like they don't know what is happening, but they are sitting on the fringes of monitoring everything that you are doing in the health ministry or in the department. And with that level of confidence, you see resources, more and more resources are also coming. Thank you. That's my little contribution. Partners pretend like they don't know what is happening.
With that excellent contribution from our elders, and you know what they say on Africa, the world of the elders are.
And with that level of confidence, you see resources, more and more resources are also coming. That's my little contribution.
The world of our elders, you must listen. Let me put it that way. So thank you, Your Excellency. So at this junction, we've come to the end of this morning technical session, and the only thing that is standing between us and lunch is for me to do some housekeeping announcements. So we know some delegates are fasting, and so please, those that are fasting, morning technical session and when you go back to the hotel at the time of iftar, give them have your iftar as if you are having lunch. There will be a fresh hot meal for you at the hotel. So collect the coupon and keep. That's the first announcement. The second is because the African Union have some financial ways of carrying or activities like this. Please may I request that you keep your boarding pass. We'll arrange for somebody from the finance or Africa CDC to come and collect those boarding passes and any other documents that may be required to properly retire this meeting in terms of finances. So I think those are the two. Adelaide, boarding passes. Did I miss any? That's okay. Good. Thank you. So those are the two announcements. The time now is 20 properly retire this meeting in terms of finances. So am I right? 20 to 3. So we'll come back 20 to 4. 1 hour. Good. Yes. Let's take 1 hour for lunch. But we'll come back the post-lunch session. We'll make it a bit Africa. Thank you, colleagues. Can we give ourselves a round of applause? So we will come back 20 to 4. 1 hour. Good. Yes. Let's take and thank you to the people online. You can also take a lunch break, and then we'll come back in exactly one